สู่ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice ค่ะอาทิตย์นี้เป็นอาทิตย์ที่8แล้วนะคะซึ่งเราก็จะกลับมาพูดถึงในเรื่องของ CR แล้วก็ DR Radiology นะคะในเรื่องของเพนฟิล์มที่เราถ่ายภาพกันนะคะว่ามีในเรื่องของ Imaging Technique อะไรยังไงบ้างนะคะมีในเรื่องของ Dose Metric อะไรแล้วเราจะ Optimization ยังไงนะคะแล้วก็เช่นเคยนะคะเราก็ได้รับเกียรติจากผู้เชี่ยวชาญของ IAEA นะคะดร. Sam Brady นะคะจาก Cincinnati Children's Hospital ที่มาพูดให้เราฟังถึงในเรื่องของ CR แล้วก็ DR แล้วก็แถมอีกนิดนึงนะคะวันนี้ก็คือได้รับความกรุณาเป็นอย่างสูงเลยนะคะจากคุณแซมที่จะมาพูดถึงในเรื่องของโควิด -19 ค่ะเนื่องจากอาทิตย์ที่แล้วเราคุยกันว่าในคนไข้ของโควิด -19 ในประเทศไทยณตอนนี้เนี่ยซึ่งเราอยู่ในโรงพยาบาลสนามค่อนข้างเยอะเราก็จะมีความจำเป็นในการที่จะต้องสกรีนนิ่งด้วยเรื่องของการใช้เอ็กซเรย์ปอดนะคะแล้วก็การถ่ายเอ็กซเรย์ปอดในโรงพยาบาลสนามซึ่งเป็นในสภาวะที่เราไม่ได้คุ้นเคยเท่าไหร่นะคะอาจจะมีความจำกัดในเรื่องของพื้นที่นะคะที่เป็น open space นะคะหรือว่าเราต้องไปถ่ายคนไข้ที่ต้องกักตัวอยู่ในห้องแยกซึ่งต้องใช้ double glass เทคนิคอะค่ะมันจะมีในเรื่องของเทคนิคหรือการปรับพารามิเตอร์อะไรยังไงบ้างในเรื่องของเอ็กซเรย์ที่จะได้ให้ภาพที่สามารถตอบคำถามได้แล้วก็ยังมีความปลอดภัยต่อนักรังสีเทคนิคในการที่ต้องเข้าไปสัมผัสผู้ป่วยนะคะก็เดี๋ยวยังไงครั้งนี้ก็คือจะได้รับความกรุณาจากคุณแซมมาเล่าให้ฟังนะคะ Good evening Sam nice to meet you again and welcome to IAEA Expert Mission so this week is week 8 that we are going to talk about CR and DR imaging and you're going to talk about the imaging quality metric and also optimization and you are very nice and you agree to give a talk and tell us a little bit about the check X-ray in the COVID-19 patient, which right now is a pandemic situation in every places in the world. And right now in Thailand, we are facing with the third wave of COVID-19, which is like we have like a high number, a lot of complication or consequence from the COVID infiltration in the lungs. And we have a lot of patients in the field hospital and also in the isolated room. So you're gonna give us some idea or guideline or maybe some rationale that has some like a physics involvement on the imaging technique. So I'm going to give you a floor to talk about the imaging quality metric and optimization first, and we can move on to the next talk on the COVID-19 imaging technique. So welcome.
Thank you. It's great to be with you guys. I'm really excited to be back. We're going to be talking X-ray, of course, as Tanya mentioned, DR and CR. And normally this talk would be broken into 2 sessions, and then next week we'll talk about the dose component to X-ray. But because we're going to talk a little bit about COVID imaging today, I took the 2 talks and put them into one, and then the first talk is really going to focus on the imaging principles that we need to consider for good image quality and how to optimize the image quality. And then from there, you'll see how these principles are applied then when we're doing imaging in a COVID scenario where it's not ideal. Mostly it's going to be mobile imaging, and it's going to be shooting through doors and doing all kinds of stuff that you're not normally doing in a radiography in a radiology clinic. So we're going to set the stage. There we go. And we're going to talk, as I mentioned, about the image quality and the various different physics components or aspects of that affect image quality. And I would like to mostly focus in on talking about a couple of these. First is spatial resolution. So we're going to focus in on the various different effects that affect spatial resolution, such as geometric magnification, the focal spot size, and how the focal spot size will also limit what kind of radiation output we can do. The choice of focal spot size will affect the KV and the MA and the time, so the mass. And then it also affects where in the image the resolution is the best. The top, the bottom, the left or right. We'll talk about how spatial resolution is not the same all over the image like we're used to in, say, CT, for example. And then the other aspect I want to talk about is contrast. And what are the factors that affect contrast? Well, we know KV and the beam quality, which we could define as half value layer, and then some of the components that we use, such as grids. And we're going to then talk about the post-processing software that all of X-ray and CR, the DR and CR systems have, and how the post-processing actually will greatly affect how the image looks at the end. And so we obviously want to make sure we acquire the right image with the right technique, but then I'll show you how using post-processing techniques we can actually modify and still do our best to get the best image, even if the image quality is not the most ideal. So starting off talking about magnification. When we're imaging in a normal clinic, we're either going to place our patients on the table, they may be standing up, facing the wall chest bucky or facing the X-ray tube. And in some cases, if you have a portable detector where you can take the detector out of the table, such as a digital detector or such a CR plate, you can place the patient's anatomy directly on the detector itself. So we all understand this, right? You guys use this every day. You place the X-ray detector, either digital or CR, you put it inside either the table or the wall bucky. But because of the geometry, there is always a space between the physical detector and the cover or the tabletop. There's always a space. And that space causes magnification because the patient's anatomy or the patient themselves, they are elevated away from the actual surface of the detector. So in X-ray, in DR, CR, it doesn't matter. In X-ray, all imaging we do causes patient anatomy to be elevated and therefore magnified. So the mathematics behind this are pretty straightforward. I'm sure you guys remember all this from your days when you were in school, as for technologists, physicians, or radiologists or physicists. When we look at the source, and if we look at the distance from the source to the imaging plane, this is called the source to image distance, or SID. In this geometry here, you can see how it's the distance from the object added to the distance to the detector, or A plus B. And then we divide that, it's a ratio of this source distance to the object, or SOD for short. So the mathematical equation for magnification is SID over SOD, or in this case, A plus B divided by A. And what this gives you is magnification, but the thing that you'll notice is that no matter what you do, this distance here, denoted as B, will never be 0. So it'll never be a ratio of A divided by A. It'll never, ever be magnification equal to 1. And that's because we are 3D by nature. Even the thinnest part of our body, a finger, is still going to have some apparent magnification, albeit smaller than maybe a belly or a chest. And this is principally why when we look at an image, a PA projection will have a different look than an AP projection. And I know you all know this, when you place and you acquire a chest radiograph, an AP image will have a larger heart. And so it's not cardiomegaly we're looking at, it's just the fact that physically the patient's anatomy is magnified. And so this is principally why the technologist will place a marker on the either a physical lead marker, so it'll appear on the image itself, so the radiologists know the orientation, or they'll digitally make one after they acquire the image. And this is important for the radiologist, though there are telltale signs that this is an AP because you can see the scapula here, but it's always good practice to tell the radiologist the orientation by putting it, AP, PA, lateral, etc., even though sometimes it's pretty obvious. So magnification is something we deal with all the time in radiography. In fact, in a couple of weeks when we talk about mammography, we'll talk about how geometric magnification is actually used to our advantage. And last week we talked about how geometric magnification in fluoroscopy is actually a bad thing, right? We talked about how that increases the dose to the patient due to the technology in the fluoroscopy system. So magnification can be both good and bad in radiography. So how does it affect us in radiography? So in CRDR. Well, we have to talk about one more thing first, which is the focal spot size, and then we'll bring together the focal spot size and magnification. So the focal spot size is an option. All modern X-ray systems will let you usually pick between a small or a large focal spot. And if you have a really high-end system, you might actually have 3 focal spots, small, medium, and large. And this is basically just the amount of photons that are the amount of electrons produced in the X-ray tube. And as they strike the anode or the target, how focused they are, it will tell you the size of the focal spot. And we'll talk about that in a minute. So nonetheless, the smaller the focal spot, the less edge blurring you will get on an object. And that is because a small focal spot will cast a small shadow from the edge of any object. A large focal spot will cast a larger shadow. This shadow is called a penumbra for what it's worth. But nonetheless, what it does, the effect of it is it causes basically to soften the edges or create somewhat of a shadow and a blurring effect to the edge of any object. So in a perfect world, we would do everything with the smallest focal spot possible. The limitation to that, as we'll talk about in a minute, of course, is if you're putting a lot of electrons in an X-ray tube onto a teeny little spot on the target, it's going to cause a lot of heat, and therefore it could cause damage to your X-ray tube. And so small focal spots are limited in the amount of radiation, amount of X-rays we can produce. So we're limited in the MA and KV, primarily the MA that we select. So how do we combine that? So what does that mean also with respect to magnification? Well, the focal spot, of course, the size of the focal spot will change this shading, this shadowing, which is the blurring effect on the edge of any object. Any object that is not directly touching the X-ray tube, so if it's off of the X-ray tube, it's somewhat spaced away due to magnification effects, it will also cast a larger shadow here. This penumbra will get larger. So larger focal spots and objects that are farther away from a detector, those two things cause blur in the image, cause the edges of an object to become softer. Here I just gave you the math. You can look at that if you're interested when you get my slides, but I'm not really going to focus as much on the math, but just the principle here, the idea that we're trying to talk about here is the object we want to image, we want to get it as close to our detector as possible. And that's why for small parts, it's great to do it if we can on the tabletop. And we'll talk about some other issues about, we'll talk about in a little bit about some other things we have to modify. But we want to put our objects as best we can close to the detector and use our small focal spot. And you can kind of see this in another way. If you have the object as close to the detector as possible, the edges will be cleaner and crisper. The farther you pull away due to magnification, the softer or more blurry the edges are. And that same effect will also occur if you have a larger focal spot. So the farther away an object is from the detector and the bigger the focal spot, the blurrier the image will always be. All right, so the trade-offs, I kind of mentioned this already, but we will typically, the excuse me, the focal spot, the large focal spot size is typical in X-ray machines nowadays, are about 1.2 millimeters. And they primarily do this so that we can control the amount of heat produced inside the X-ray tube, which will allow us to image with more MA. And that is good when we're penetrating denser parts of anatomy, say our pelvis, or bigger parts of our anatomy, such as our abdomen. Smaller focal spots will give us, are typically about 0.6 millimeters, so about half the size, which causes heating issues, may cause heating issues, or is at least limited to the amount of MA that we can use. But it does provide the best resolution, best spatial resolution in the image. So just a quick summary to this point in the talk. The farther away an object is from the detector, the greater the magnification. And the edges of the object will be more blurry. Smaller focal spots will minimize the edge blurring, but is limited to the amount of MA we can produce. And so this is primarily low MA, small focal spot is primarily used for maybe extremities. So we have smaller, thinner body parts, or body parts that if it's a little noisy, it's okay because we're looking at bony anatomy. And then of course, really small patients such as neonates or very young pediatric patients. Okay, so we need to talk a little bit now more about the focal spot. And so how else does a focal spot affect spatial resolution? Well, we know that the size of the focal spot means something, and the size is based on this angle. So the anode, the target in the X-ray tube, is not flat because that would not distribute the heat as well. So we actually tilt the angle just a slight bit, and that allows this physical principle called the line focus principle. And what that means is the amount of electrons that come from the cathode and strike the target or the anode, this area is always larger than the area that comes out, the output. So the input is bigger than the output. And that's a good thing because this allows us to actually control the heating on the X-ray tube better. And this allows us to use a higher MA. So the line focus principle is a good thing from a technological standpoint of keeping the heat under control. So we can acquire more X-rays over the course of the day, and we don't have to wait as long for the X-ray tube to cool off. So what does the line focus principle also affect? Well, it also affects where the spatial resolution is the best in the image. And so because the image, the X-ray beam comes out of the X-ray tube, it diverges. It's going to diverge both in the kind of the left to right and the superior to inferior direction, so the top to bottom. And resolution is always going to be the same, as in the resolution is the same quality when you're looking at typically left to right. And it will change when you're going along the main axis of the body. Now, this is actually that's kind of general terms, generally speaking, but it also it's actually more specifically dependent on where the axis of the X-ray tube. So when you look at an X-ray tube, you obviously know that there's an anode side, which is the target, and a cathode side. Most modern X-ray tubes will actually have a little plus sign on one side and a minus sign on the other. If your system doesn't have it, you can always ask the vendor and they will tell you which side is the anode and the cathode. But the trick I always use is if my X-ray tube, if it's an older system and it doesn't actually tell me which side is the plus side or the anode, which side is the negative, if you go acquire 5 or 6 X-rays and go put your hand on the side of it, the side of the cathode will be cooler than the side of the anode. The anode, the target side, is obviously going to be the hottest side because that's where all the electrons are striking. So if you physically just put your hand on one side and it's cold, that's the cathode side, and you go put your hand on the other side and it's hot, then you know that's the anode side. So nonetheless, the resolution is based on this axis, the anode to cathode axis. So the length, or I guess the width of the X-ray tube itself. And so when you look at it perpendicular to that, so which is typically left to right in our patient axis, the resolution is going to be the same. from left to right. And that's a good thing. That means the structures, when you look left to right, will have the same ability to resolve a small structure. It won't change. But when you look at it going now top to bottom or superior to inferior, resolution is always, always, always the best on the anode side. So in this case, in this scenario where we're doing a chest radiograph, well, actually it looks more like a spine, then the resolution is going to be best up here in the clavicle areas, and it's going to be the worst or poorest down here, more towards the mediastinum. All right, there's another effect that happens, and that is because the anode or the target is angled, the amount of photons that come out of the X-ray tube are not equal across this field of view. We actually get more photons, more X-rays that come out on the side nearest to the cathode, and the side nearest to the anode, there are fewer photons, fewer X-rays coming out. This is called the heel effect. If you think of kind of the shape of your heel, we have kind of a spectrum where, not a spectrum, an intensity curve where you get a higher intensity curve on one side and a lower on the other side. So it kind of looks like a heel. And now this means that we'll get better penetration of the X-ray tube. The beam coming out of the X-ray tube collimator will penetrate better on the cathode side. And it'll actually be as much as about 25 to 30% different. So, and this is why our technologists always align the cathode to the mediastinum. It's not necessarily because they're thinking resolution, although they may be doing that. It's because we want the beam with the most photons, the most ability to penetrate through the thickest part of the anatomy. So for a chest X-ray, of course, that's going to be the mediastinum here. We got our heart, we got the mediastinum, we got in case of a female, we got more breast tissue that's more inferior than up here, superior, where the beam is less intense, but there's less anatomy. So we can use these techniques. We can use this understanding when we set up our distance and we set up our size of field of view. So for the first thing, obviously, the closer we are to the detector, so let's say we're doing a normal tabletop application. So we got the patient on the table there, and forgive me, in England, in America, it's always in inches. So it's 40 inches or about 102 centimeters from the source to the tabletop. Here, you're looking about you would see a much stronger difference in the beam intensity going from the cathode side to the anode side. But if you extend that distance, now you're farther away in more of an upright chest scenario where maybe you're projecting it towards the chest wall, the wall bucky or the chest bucky. Now you can see how the beam has diverged much more. And so in this animation or this graphic, you can see that the beam intensity is actually much more uniform for greater distances. And that can also be the same if you're using smaller field of views. You will get more equal uniformity across the field of view versus larger field of views where one side of the field of view will have a stronger intensity. Now, I reckon these are principles that you need to understand when you're setting up and aligning and where you're setting the distances for the patients. But in almost every case, we're limited to what we can do. You know, if you're going to image a big body, a big abdomen, you're always going to use a large field of view. That's just what it is. But this is principally why when we do chest x-rays, we typically want the patient to be extended away from the detector. This is why we usually set them up at, 72 inches or, 140, 153 centimeters. Whereas when we do abdomen imaging on the body, we'll put it closer to the table and we'll actually open it up a little bit, and you have a little bit more penetration through maybe what is considered the, I know I'm tapping my belly, you can't see it, but the more attenuating or the thicker part of the anatomy. So we keep that in mind, especially when we talk about COVID imaging in a little bit, because we're going to be doing a lot of extended imaging. We're going to be putting the x-ray tube at weird angles. and the detector to the body will also be at weird angles. So these principles do mean something, especially when we're imaging in non-ideal situations. So, okay, another summary at this point in our talk. So spatial resolution is best at the anode side of the X-ray tube. It is the same, the resolution is the same, left or right, typically, or perpendicular to the anode cathode axis, and it's the worst on the cathode side of the X-ray tube. X-ray intensity is the best at the cathode side of the X-ray tube and is equal for small field, well, equal is probably the wrong word. It's more equal, it's more uniform for small field of views and at longer or extended SIDs or distances. All right, so going back to our original goals, we wanted to talk about spatial resolution, which we just did. Now let's talk about contrast. So I know you all know this. KV, especially because we actually talked about it for CT. KV will have a very large impact on image contrast. So what is KV? In modern medical x-rays, we have an x-ray tube. We have the cathodes, which is where we get the electrons. They're boiled off and they're accelerated towards the target and they interact with the target, and that's where we get our x-rays. Well, that acceleration factor, the amount of energy these electrons gain from going from the cathode to the anode side depends on the KV setting we dial in or to punch in on our x-ray machine. And so this is called the tube potential. It's generally somewhere between 20 or low values for mammography and relatively medium to high values, say 50 kV to maybe 120, 130 kV for just general radiography. When we dial in the value for kV, that's our tube potential. And that will tell you the energy of the electrons. And the energy of the electrons are defined in keV, and the tube potential is units or kV. So those units are very similar. What you will see almost always in CR/DR, we talk about kV. And when we talk about mammography, we often talk about keV, but we'll get into that in a couple weeks. So there is just a subtle difference between the two of those. So lower kV imaging leads to lower radiation dose to the patient and better tissue contrast differentiation. We talked about this quite at length for CT. So for those of you that were a part of those conversations, then this is just a review. But the idea here is this is the idea behind why we typically will image with lower kVs in most of radiography, is we're trying to reduce the dose of the patient and increase the contrast in the body. So another thing just to remember, when we change the MA, this affects the amount of photons, X-rays that are coming out of the tube. So this affects the radiation dose to the patient and the image noise in the reconstructed image. When we dial or change the kV, this also affects radiation dose and image noise, but it affects image contrast. And so that's why kV is that one knob that we have to be very careful about setting. If you've got a patient and you set them up and you've dialed in your kV, but maybe it's a larger patient, well, if you change your MA, you can affect obviously dose and image quality or the noise. But if you keep the kV the same, therefore the contrast will be the same. And so that's why in fluoroscopy, the systems do its best, will change the MA faster or more frequently. And the same thing for kV. When you have your auto exposure controls or your AEC, the MA will change much more, and you physically actually have to change the kV. So let's look at this from a physics standpoint. We've got here on this plot, you have the attenuation coefficient, or the amount of attenuation of these three objects. Obviously low attenuation versus high attenuation. So low attenuation means the photons will just fly right on by, won't stop, they won't interact with an object or the material. High attenuation means they stop and they interact and they get fully absorbed. And the amount of attenuation that happens in our body depends on the energy of the photons that are coming out of our body. And remember, that's why the units are in keV. And when we look at the typical types of tissues. We have soft tissue. In this case, I'm going to use water, which is this blue curve, this lower curve, and then bone or calcium, which is this green curve right here. And then we oftentimes, and we'll talk about this in the next slide, but to enhance our contrast, we'll usually inject iodine or maybe barium, which basically has kind of a similar curve. And you can see that there are differences between these curves. And where there is the greatest difference between these curves, that means those images will appear those objects will appear the most distinct in the X-ray, in the actual radiograph. So if we're imaging at relatively low energies, low KVs, soft tissue will stand, the bony anatomy in the soft tissue will look very distinct, grays versus whites. The higher the KV, you can see these curves basically come and they overlap. So the higher the energy that we dial in, the higher the KV setting, the less the bony anatomy and soft tissue will be distinct. They will become more and more the same grayscale value. So this is a bad thing. But there is actually an upside to this when we're imaging the chest. When we go, obviously, if we have low KV, the bony anatomy is going to stand out more from the soft tissue because you've got better contrast, the better difference. So here you can see there's a bigger difference between this bar and this bar, and that just represents a higher contrast between soft tissue and bone. Now, if we use a higher KV, this difference is actually less. So the bony anatomy will kind of, I guess, it will not stand out as much to the eye. It'll be more in the background. And that's okay, because when we're looking at a chest radiograph, we're also what we're mostly trying to do is look into the lung parenchyma. And lung parenchyma, of course, is filled with air. And so it will always have very strong contrast. Now, you can tell that the black in the lung in this image is actually a little less. It's more gray. It's a little less black. It's less distinct than this image. And that's part of what happens when you use a higher KV. But the better part is the bony anatomy, the ribs, they become easier to see through. And so we see more of the lungs. And this is a principle that we're going to need to use when we image for COVID. But this is why when we do chest radiographs, we use a higher KV. When we use abdomens, which are actually more dense than our chests, we use a lower KV because we want to see more differentiation. We want to do our best to differentiate the soft tissue, of course, from the bone. But if there's maybe air in the colon or in the, in the intestines, we want to be able to differentiate all that. And the only way to do that is to go to lower KVs. Now, we've talked about how the soft tissue and the bone, we want to image as best we can where those two curves are the farthest apart. You'll never get those two curves really far apart. And that is why we almost always, especially in CT, inject intravenous iodine. And that's because you can see this iodine curve really is much, much higher than the blue curve, the soft tissue. And so when you do IV contrast, and obviously we don't do that as in X-ray, we may do like a barium, we might do an oral contrast, in which case we're going to then coat the colon, and that will give us a better appreciation of the outline of the colon and the wall and the edges of the colon. But the whole reason, it's the same principle here as we're doing with this iodine. And one of the benefits to this iodine and the barium is there's what's called a K-edge. This value where the attenuation properties go from very low to very high almost instantaneously, and almost at the exact over a very, very short amount of change in energy. And so the closer we image to this K-edge, you see you get this nice enhanced from, if this curve was continuous, it would go like this. It would just keep going. But because when we image anywhere between this KV and this KV, you see we get an enhanced amount of attenuation when we look at an object with that K-edge, in this case iodine. Barium will have the same concept here. Barium's K-edge is at 37. So if you just take that curve and just shift it just a little bit to the right, you would get barium, which is typically what we use in, of course, X-ray and CR and DR. So we've been talking iodine. Obviously, we use that a lot in CT, but you can see here that lower KV, how it makes the calcium or the higher atomic number structures in our body stand out more from the soft tissue, in this case, water type soft tissues. And the higher the KV, the two become more the same. They take on more of the same grayscale. All right. So KV directly affects contrast. What's another thing that affects contrast? The amount of filtration that we use. So when you're imaging, you will oftentimes pick, your X-ray machine will have multiple options for filters. Maybe 1 millimeter of aluminum, 2 millimeters of aluminum, maybe 0.1 millimeters of copper plus 1 or 2 millimeters of aluminum. Some combination of filtration is usually available. And we almost always will pick filtration for, as an example, the chest. What we do at our institution at Cincinnati Children's, we use 0.1 millimeters of copper and 1 millimeter of aluminum for almost every application except for very small body parts in babies, baby abdomens and chests. And we do that for this purpose right here, is when you use more filtration in the X-ray beam, what you're doing is you're absorbing these lower energy photons, X-rays. And that's a good thing. It's a good thing. It creates a less skin dose, so it's a safer, quote unquote, safer X-ray beam. But the other thing it does is you can see the average of this profile. You see how this peaks right here. Let's just assume that's the average of the profile. Now, if you add a little bit of filtration, where'd it go? There we go. The filtration right here shifts a little bit to the right. And if you add a little bit more filtration, now the average is shifted a little more. It keeps shifting towards higher effective energies. It makes the beam more penetrating. It's kind of like making it a higher KV, even though, sorry, I keep pushing the wrong button. Even though the KV value we've set is the same, we are effectively moving the contrast scale by adding different layers of filtration, which once again, when we talk COVID, we oftentimes have to shoot through doors or glass or plastic, and that is the same as adding filtration that in our X-ray beam. It effectively changes the curve and it makes the beam, quote unquote, harder, i.e. less soft X-rays, less X-rays that would only be absorbed in our skin, which is a good thing. But we'll talk in a minute, because it's more penetrating, it has the ability to get into our body and scatter. So how do we measure half value layer? This is just a practical slide for those physicists in the audience that actually need to do this. I'm sure they've probably done this on many a times. So this is probably just a refresher. But here's the equation. And what we're going to do is we got our X-ray tube, we got the machine collimator. And what we're going to do is we're going to add a variety of filters. And every time we add a new layer of filters, we're going to make a measurement with our ion chamber. And so here you go. We take our first measurement without any filters. We get our ion chamber reading and we normalize it. So now it's 100%. And then we add a filter, and that's going to reduce the radiation by a certain percentage. Add another filter, it's going to reduce it by another percentage, and another, and another, and another. And you keep adding filters until the radiation beam passes the 50% mark. And of course, the half value layer, the HVL, is called that because the half value layer represents the amount of filtration that reduces the beam by 50%. So we can make these measurements, and here I just simply made this plot. I created this plot with 3 different KV values, 70, 90, and 120. And you can see that for the same amount of filtration, for the same half value layer, you need more and more filtration with higher and higher beams. And you can say that a different way. The higher the KV, it gives you, and filtration, it gives you, well, no, oops, I didn't say that right. the way I said it first was correct. So let me re-say that because I'm probably confusing you. My apologies here. That for the same amount of filtration, or for the half value layer will be different for every kV. As you go higher in kVs, your half value layer will increase. My apologies, I'm stumbling over my words. So for a 70 kV beam, your half value layer is going to be somewhere over 2.5. But for a 90 kV beam, it's going to be over 3. And a 120 kV beam, for example, it's going to be about 4.5. So that filtration in conjunction with the higher kV means the beam is more penetrating. So quick summary here. 2 potential kV. A low kV equals better bone and soft tissue contrast. High kV equals lower bony contrast. High kV equals better penetration. High kV equals more scatter. And we'll talk about scatter next. How we deal with scatter. Increased half value layer, typically from extra filtration that we add, increases that mean beam path. So it shifts the mean spectrum to the right. Therefore, it's more penetrating, and it has the potential to increase the amount of scatter from our body. But, and this is why we do it, it reduces the overall skin dose or dose to our patients. All right, so we have to deal with scatter, right? Let's talk about scatter. We don't think about it as much because when we image in normal radiography in our fixed rooms, we bring our patient, we lay them on the table, there's always going to be a grid between the table or the patient and the detector. Same with it on the wall bucky. When you're doing your portables, you usually have a snap-on or a cover grid. So we just don't think as much about grids as much because we use them all the time, every day. They're going to be important when we talk about them in COVID imaging. But what we deal with here is the grids are what help us regain or preserve as much of the signal to noise ratio and the contrast noise ratio. So you can see here, I just had this phantom. So I went and imaged it. These pictures I actually took from the web, but I did this with my own phantom. I guess I just didn't use those images. And if you image it without a grid, you just get a lot more scatter. So therefore the contrast goes down. So it's just more of a uniform grayscale throughout the image. It obscures a lot of the anatomy. Even though this is a phantom, you don't see anatomy. When you use the grid, of course, it cleans up and gets rid of that grid. That scatter. Here is an actual patient anatomy. In this case, you see no grid on the left, more scatter. Definitely you can't see penetrate through the mediastinum, harder to see. With a grid, you get better, obviously, vertebral definition, better penetration, less scatter through the soft tissue. Same thing down in the abdomen. No grid, harder to see the colon, even with the air pockets. Definitely hard to see any of the other anatomy. And then with a grid, you can see a lot better soft tissue. Definitely you can see the bony anatomy. All right, so how do we define the amount of scatter in an image? That is defined as the scatter to primary ratio, or SPR. Scatter to primary ratio, when we have equal amount of scatter in the image, equal amount of photons that come into our body and scatter, versus equal amount of primary radiation that goes straight through the body and to the detector. So primary is the photons that the x-rays that go straight through the body and get to the detector, versus scatter that comes in, scatters, and then gets to our detector. If you have an SPR equal to 1, the ratio means you have 50% of the image, the reconstructed image, 50% of it came from scattered photons, and 50% of it came from direct primary radiation that went straight to the detector. So when we have an increase in SPR, that comes from usually where we have larger field of view. So it's the volume of tissue rated. So larger field of view or thicker patient, or both, large field of view plus thicker patient. So here you can see that we can reduce the amount of scatter in the image, or reduce the SPR, by tight collimation. And that's probably one of the easiest things we can do to improve image quality. The second is the composition of the tissue irradiated. Bony anatomy is primarily going to be imaged using photoelectric effect, i.e. the photons will come in, they hit the bone, and they will get absorbed. Whereas in soft tissue, the photons will come in, they get the soft tissue, and they scatter. And that's due to Compton scatter effects. And then KV, which we've already talked quite a bit about, higher KV scatters more. Lower energy is absorbed through the photoelectric effect. So low KV undergoes photoelectric effect, medium to high KV goes through a lot more Compton scatter. Here you can see the scatter to primary ratio as a function of field of view. So for smaller field of views, you can see as the field of view gets bigger, for a thinner patient, you can see that the scatter to primary ratio stays relatively low. As the patient gets bigger, obviously the scatter content goes up as fast as the field of view. And so I guess the saving grace, if anything, is the very large field of views, say 20 to 30 centimeters. So let's say you're doing a big abdomen. If you bring it in from, say, a 30 to a 25 centimeter field of view, you're not actually changing the scatter content much. It's more of a difference of if you have a chest radiograph or a body and you open it all the way up to 30 centimeters, but the body itself is small. And if you could bring it in to say 15 or 10 centimeters, then that's where you start to get savings from scatter. So here you can just kind of see this as an example. These are two different types of X-ray machines. You don't have to worry too much about it. I just simply am demonstrating how when you reduce the amount of scatter or lower the scatter primary ratio, you can see the image better. And the first one, or the image on the left, this is a full field imaging device, which is just our normal X-ray machine that you have in every room where you can control the field of view using your little knobs. It's a full field, large field of view X-ray machine. You can kind of see the noisy anatomy, the noise superimposing the anatomy, and it's kind of hard to see the structure of the bony anatomy. It's there. This is the same phantom image on both devices. In a different type of machine that has what's called a slot scanning, such as if you have an EOS machine, where this patient is standing upright and the machine will scan down, will kind of raster the body. So the detector itself is actually is relatively small, and so it's very small collimation. The X-ray tube and the detector slide down, and because of that, it reduces the amount of scatter by 87%, roughly 87%. And really, when you reduce the amount of scatter, you get really good clean images. And that's what this study looked at here, published in Radiology. And I'm not going to go through the details of it, but you can look at it using being able to reduce the amount of scatter using, as an example, slot scanning. You can see that the amount of scatter in the image really reduces in every part of the body: lung, mediastinum, subdiaphragm, etc. In the mediastinum around the heart. So how do we get rid of scatter when we're imaging using just normal planar radiography and mobile X-ray machines? Well, we have to use a device called a grid. And I know you all know this. So we place our patient in, we place them directly on our detector or on their table, and we have this grid that's aligned here. And the purpose of this grid is to let the primary radiation through. As the photons transit the body and do not interact, they should then go straight to the detector and get detected. And that is going to give us the nice difference in contrast versus the other photons that'll come, get absorbed, and not ever go to the detector. So that gives you your black and white in the image. But then the photons that come here and scatter, and instead of being imaged here, they get imaged over here. Well, that just adds noise, and that adds that gray haze over the image. So there are two types of grids to help to eliminate as much of the scatter as possible. The first is a moving grid, and it's necessary. We use these moving grids when we need to image real high resolution detector systems. So the really small pixel element DXL values of a modern X-ray machine. We absolutely need moving grids for that. The moving grid, it's placed in the grid itself is moved into a system called a bucky, and that will actually move it. It'll basically vibrate the detector in a pattern such that when it's being imaged, it blurs the grid lines out. And that is why you don't actually see the grid in the image, because it's blurred out as it's moving. And then there's stationary grids, which we use for mobile devices, and we'll explain that in a minute. So just a fun fact, why do we call it the Bucky? You know, the tray that we place the detector in, and the table on the wall. Well, it's named after a gentleman named Gustav Bucky. He's a German that was an inventor. And so way back in the day, we're talking early 1900s, the physicists and the engineers were actually the radiologists. They were actually the physicians. So if you went to the doctor and the doctor actually says, okay, let's take a new Röntgen ray or a X-ray of your body, they sent you to a radiologist, and that radiologist was a physicist or an engineer. And so Gustav, or Dr. Bucky, he would help. He was a radiologist, made a lot of images, and he got to be very good friends with a person named Albert Einstein, who I know you all know. He helped treat his wife several times. And he came up with this idea to create a grid to reduce the scatter to make the images easier to view. And because Albert Einstein, before he became world famous physicist that came up with E equals mc squared, he was a patent clerk in Germany. And so as a patent clerk, he helped Gustav Bucky patent the grid. And that is why today we call it the Bucky system. And that is inversely or somewhat correlated with Albert Einstein. Albert Einstein's kind of a funny guy. He invented so many things. Here you can see, the reason I gave you this little newspaper clipping is because it mentioned Dr. Bucky, but it talks about Albert Einstein inventing the camera iris. And so Albert Einstein invented a lot of things, but the whole reason that we can use our cameras on our phones and we can actually zoom in and zoom out, that iris that constricts, you're looking at the man that invented it, Albert Einstein. So he figured out E equals mc squared, and he also made it possible for really high-end electronics and cameras. Now, that's a tangent, sorry. Gustav Bucky came up with the grid, but he actually put the grid below the patient and above the patient. And that was really effective at getting rid of all the scatter. The problem is the image looked like this. It was a checkerboard. You could actually see the grid lines because A, it was over top of the patient, so it projected those lines through the patient. And B, the grid was not moving. This gentleman, Hollis Potter, he was an actual radiologist. So fast forward, I think about 10 or so years, now radiologists are MDs, they're physicians. They're not necessarily engineers or physicists. And this guy, he realized that you can only look at the image with so many lines through it, and you just can't be diagnostic as much. So he came up with the idea of moving the grid, oscillating the grid, such that you were going to blur the lines. So you can see his little device he created. You put the patient in, and you would physically move the grid. Now, back in the day, when you would create an X-ray, so we're talking 20s and 30s, it would take, there we go, several minutes to make an exposure. So today we pull the trigger and it's done in a quarter of a second. It's done in just super fast. Back in the day, because it would take a couple minutes of just X-ray on time, they could just sit and physically move the grid, and so they didn't have to go super fast. Nowadays, the grid itself has to oscillate in 1/20th of a second. It has to go super fast. And it does that so that we don't see the lines. They're not superimposed on the anatomy. The other thing is we don't use Gustav or Dr. Bucky. He had the matrix, the squares. We actually still use that. We use this in mammography, and we'll talk about that in a couple of weeks. But for X-ray, we just use long parallel pieces of metal, typically aluminum, can be something else, could be lead. These are called septa. And these are the things that absorb the scatter. So when we talk about a grid, and when you pick a grid to use in your X-ray machine, either the table, the wall Bucky, or a mobile unit, there are three things you have to get right. you have to pick the one with the right grid ratio, grid frequency, and the grid focus distance. So let's talk about that. What is the grid ratio? This is defined as the space between the septa. It tells you how much space you have between each septa. Now, all of these systems, the grid, it's not actually air, because if that was the case, you could just hit it and you'd bend all the septa and it would be useless. So there's actually either aluminum or some type of polymer or plastic. And that spacing is what, that material is what keeps the septa rigid. But the space between that is the grid ratio, how closely you can place the septa or how far apart you can set them. And it's defined as, no, excuse me, I misspoke. The spacing, that's defined for the frequency. My apologies, that's the next slide. The grid ratio is the height versus the width. And so if you have a septa that is so tall versus how much space there is between each grid, that's the grid ratio. Most of these systems, for example, most X-ray units in there for the table and the wall bucky are going to be somewhere around a 12:1. That means the septa are 12 somethings, 12 millimeters, 12 microns, 12 somethings higher than they are farther apart. So they're actually very finely spaced and they're relatively tall. When we go to, say, mammography, which is low energy, we can't do it. We have to actually spread them out a little bit. And so we use a 5:1. Fluoro is somewhere in between. The higher units can get up to as high as 12:1. So why do those numbers matter? The higher the number, so the closer they are spaced together, that gives us better scatter rejection, which is a good thing. But it also absorbs more of the primary radiation that's trying to pass through. So that is a bad thing. Therefore, we need to get more primaries through, so we have to turn the radiation up. So the higher the number, the higher the ratio, typically higher the patient dose, because we have to compensate by increasing the MA. All right, this is what I originally started talking about, which was the grid frequency, which is the spacing, the thickness of the septa, plus the spacing of the material, the interspaced material. And when you look at that and you take that ratio, that'll tell you how many septas per centimeter you can have. In this case, from this example, if this is a 45 micron thick septa, and there is basically 120 micron space, you do the math. Here I converted it to centimeters. That means there are 60 of these septa and interspatial material pairs, line pairs, 60 of them per centimeter. So that's a centimeter, is teeny. That's a lot of septa there. And so it does a great job getting rid of the scatter, but it will absorb a lot of the primary radiation. Typical oscillating grids will be somewhere around 70 to 80 of these line pairs per centimeter. Now, if you have a stationary grid, so this is for mobile units, the technologist isn't going to sit there and shake the detector while they're when they're trying to irradiate. It just doesn't work. It would be funny to see, though. We have a stationary grid, therefore we actually have to have a lot finer or a higher frequency. So now we need 80 to 100 of these line pairs per centimeter. And the reason for that is we actually need the spacing to be smaller than the smallest element on the detector, which is the pixel, as you can see here. So they have to be smaller than that. If they're smaller than the pixel, then they are invisible to it. And so we make the grids invisible on the image because we make them so finely spaced, so close together, that the detector itself can't see them. All right, so that's grid ratio, that's grid frequency. The other thing we have to worry about is the distance, that focus distance. So what happens is these grid lines, these septa, are not actually parallel. They're actually cantered in, or they're at an angle. They're set to be at the same angle as the X-ray beam divergence. Now, the divergence, obviously, as you go close, when you're close to the source, there's a very small divergence. The farther away, the bigger the divergence. So you have to change the angle of the grid lines, the septa, depending on how close or how far away you are from the source. Therefore, you can't have just one grid and place it anywhere along the distance between the source and the patient. You actually have to have 2 or 3, maybe 4 options. So we talked about how grids will decrease the amount of primary radiation, but they will significantly reduce the amount of scatter. When you look at the actual math here, the grid, the septa, will cover actually about 30% of the field of view. So when you slide that grid into the field of view, you are immediately covering up 30% of all the anatomy. And so what that means, and obviously that's why we shake it and we blur it out so you can still see the anatomy. But that means the transmission factor is only about 50 to 75%. So we absolutely need to turn up the radiation to get this number as high as we can. You know, we want a high transmission value to get as much photons, primary photons through. The scatter factor, the scatter transmission, you can see is actually much lower, 5 to 20%. So that's the key here. You want to get this number the highest and this number the lowest. And when you turn up your MA, obviously both of those numbers are going to go up. If you increase the grid frequency to go to a higher number, this number goes down and this number goes down. So it's just that crazy juggling that we have to do. All right, so we talked about needing to set the right distance. The idea here is if you get the right distance, then the primary beam will be properly aligned. It will pass through each of the septa, and we won't worry about that. If it's not properly aligned, so if you get the wrong one and you get it too close or too far away, here you can see the photon, the primary beam, will actually get absorbed by some of the septa, typically around the edges of the field of view. Now, obviously, if you do things crazy like turn the grid upside down, or, which is more typical in mobile imaging, you don't get the X-ray beam perfectly perpendicular. Sometimes the grid itself will be cantered at an angle, or the X-ray tube itself will be at an angle. And we'll have to deal with this also in COVID imaging. And all of that, if it's not properly centered, if it's at a weird angle, you can get what's called grid cutoff. And it'll basically reduce the amount of photons in a specific portion of the image. So when you do set this up, here you can see these 3 things. We have to pick the right grid ratio, grid frequency. Here, this one's got a 60. So it's 69 pairs per centimeter. Here it's a grid ratio of 10 to 1. So that's a height of 10 for every basically centimeter of coverage, or actually I believe it's millimeter. And then the focal distance. This scatter grid must be used at approximately 130 centimeters or thereabouts. I mean, there's going to be a little bit of, see here, this one talks about how it can be anywhere between 103 and 140. So usually there's a little bit of a range that you can use it. But if you go outside of that range, that's when you get the grid cutoff. Now that's how we've pretty much always operated in time. There are new technologies out there that are allowing us to reduce or turn off, not even use physical grids. They are software-based grids. So no physical grid. The computer itself is able to recognize the scatter properties and remove them. So here you can see an image normal without the scatter software on and the virtual grid, and here it's turned on. Same thing, no grid and no software fix, no grid, but with the virtual grid software turned on. And it's actually pretty good. It's getting better. We're mostly seeing this rolled out, of course, in portable imaging, but we're starting to see this in some of the fixed rooms too. So the second summary when it comes to contrast is talking specifically about scatter. So scatter reduces image contrast, it obscures patient anatomy. We know that, right? Reduces scatter how we reduce the scatter in the image is we use low KV when possible, and we use grids with the proper grid ratio frequency and distance, focal distance. All right, so last thing we're going to talk about is doing what's called post-processing. So every image that's acquired is, when it actually comes out of the detector, doesn't look really good. We have to take it through a variety of steps to make it look good so that our radiologists are happy with it. And so we're going to go through every one of these steps. The very first one is image correction. And so we're going to take the raw data and we have to do the raw system data and make it clean. And this is something that actually happens every day, and the technologists should be doing probably about every month. So the system, if you actually just went, put the detector in, took a picture without anyone in between, nope, we're not imaging a patient, and we turned off all the corrections, you would see lines through it where some of the pixel units just don't work. You'd see little dead spots where that pixel is dead, and this white spots where the pixel is stuck on. So no matter how many photons it gets, it reads out a large number. So we can correct this. We're going to make a few corrections. The first is called a dark noise correction. That's actually, we correct the signal intensity without any photons, without any radiation. Then we make, and that'll fix some of the imperfections. And then we'll make what's called a gain correction, where we'll pull the trigger and we'll image the detector without anything in the field of view. And then we will make what's called an inverse correct of that. And we basically go, okay, this is a dead pixel. We can just assume, we can average that out. We can do mathematically correct that. And so we can go through these very quick steps to get it so that a nice uniform flat field image will look, basically uniformly gray. The system that does this, the system does this basically throughout the day on its own. It's making dark noise and some raw corrections. Even sometimes you'll pull a trigger and you'll go set the patient up, come back in and pull another trigger for another view, and the system will have calibrated in between those shots. But to do the actual, and probably one of the more important one, which is this gain and pixel correction, that's where the technologist has to, usually every month, they have to take in a filter and they actually have to image the detector. And this is for digital detectors, I should be very specific about. And they do that, and that helps keep the image nice and uniform. All right, so now that we have the detector, the digital detector, it's nice and uniform and it's ready to be used for patients, we acquire an image of a patient. The problem is these digital detectors are incredible. They can take a very, very weak signal and they can also image a very, very strong signal. And this will give you a dynamic range of black to white of about 1 in 100,000. And our eyes can't process that many steps of grayscale. And so what we do is we actually mathematically create a log. We just take the log of the exposure. And so for every 10 steps, for every 1,000 grayscale steps, we turn it into 10 values that we will present on the display in the reading room. And so it basically compresses the data so we can view it. So how many grayscales can our eye typically see? So going from black to white, we can typically see about 720 gray levels under an ideal setting. So this would be a perfectly calibrated reading room monitor in probably a black room. So you turn off all the ambient lights. There's just no reflection, no reflection off your monitor. You could maybe see 900, 920 grayscale levels. So if our eyes can see somewhere between 700 to 900 grayscale levels, that means our images don't have to be any better than a 10-bit image, because 2 to the 10 is 10 to the 24. And therefore, our eyes cannot see 10 to the 24 or 1024 grayscale levels. And so by changing the bit depth, if someone ever came to you and says, I can make your images better if I give you a 12-bit or a 16-bit monitor or a 12-bit or 16-bit detector, you can just laugh at them and say, that's fine. I'm not buying it though, because my eyes can't see that. My eyes can only see at most or up to about a 10-bit monitor or a 10-bit image. And that's why in radiology, even in radiography, very specifically, our images are usually 12-bit, but that's because there's some data that comes across that's just numbers. And then the image itself really only is about 10-bit. So what does that mean practically? So what we do is we will calibrate all of the monitors in the reading room to usually have somewhere between a luminance output of about 1 to 400. And this is something that usually medical physicists do. And so luminance is a measure of the light coming out of your monitor and striking your eyes. And so a very low number, such as 1, is going to be represented as black, or basically zero signal. And a high number, typically 400, is going to be somewhere in the white value. And so we turn on these monitors to usually be about 1 and 400. So it ranges between 1 and 400. We want it to be greater than 350, right? Because if we go from about 1 to 400, that is the same as presenting about 720 grayscales. Obviously, if it's 350, it's a little less, but that's okay, because that's kind of about the max our eye can see. And so at least here in the US, we have rules that say these monitors have to be set so that the white is a minimum of an intensity of 350 candelas per meter squared, but ideally roughly around 400. And we do this for 2 reasons. One, so the image itself will present with the greatest contrast. You want to be able to see the blackest blacks and the whitest whites and all the grayscale between. If you also set this number too high, let's say you go to 600, well, you're not increasing the number of grayscales you can see, you're just extending it out. And the adverse, or the biggest setback to all that, is 600 candelas per meter squared is like staring at a light bulb. And so if a radiologist ever comes to me and says, I have a headache every day after I've looked at these monitors all day, I can almost always go in and see that it's out of calibration. It's almost always set at 500 or 600. And so radiologists will be the first to tell me they complain if it's too bright. So that's why we usually set it at 400 for their comfort level for their eyes. Mammography, which we'll talk about in a couple of weeks, those values have to be a little higher. And that's because the contrast difference between glandular and fat is actually very, very small. So we really need to exaggerate the differences between every teeny grayscale step. And the only way to do that is to make sure that high end gets us really intense whites and the low end gives us really intense blacks. But we'll talk about mammography later. So now that we have log compressed, so we've compressed all the grayscale into about 720 steps, and we've calibrated our monitor, because you can do all the greatest, most beautiful imaging in radiography you want. But if the monitor the radiologist is looking at is out of calibration, they'll never see anything. So you got to make sure those monitors are well calibrated. So third step, what we're going to do now is we're going to take this system and we're going to take the image that comes in and we're going to modify it a little bit. Now, the image that comes in is simply a file or a digital file of gray and black and white numbers. And so we can create this image. We can take this image and we can create what's called a histogram, where we simply count how many black values. So if I kind of just throw up an image, we can go and count how many of the pixels in this are black, how many of them are white, and everything in between. And that's what a histogram is. And when you look at a histogram, this histogram will tell you a couple things. The first thing is the y-axis, this guy, the vertical axis, will tell you the number of the pixels for each exposure. And the x-axis will represent the amount or the exposure the patient was exposed to. So a low kV image will have a wide histogram. A high kV image will have a narrow histogram. And so I can look at this and I can basically tell you the kV. And also, if the histogram is skewed to the left, it's going to be underexposed, obviously, right? And if it's overexposed, it's going to be skewed to the right. Therefore, you can imagine, right? More black values. Therefore, this thing, the histogram is just going to be skewed more to the black side of the spectrum. And then white, if it's underexposed, it's going to be skewed that way. And an ideal one will be somewhere in the middle. The other thing about these histograms is the shape is fairly consistent with each piece of anatomy. Therefore, a chest radiograph will have basically the same looking histogram from patient to patient to patient to patient. And that's a good thing. We want it to be pretty consistent. And that's even pretty consistent from little patients to big patients, pediatrics to adults. And so you can look at this histogram and you can start to map them to points in the anatomy. So this region of the histogram might represent all the pixels in the lung. The middle might be the heart, and then the mediastinum. And of course, the air will be all the way out here. And if there's anything super white, such as bones, or maybe the collimator blade is accidentally in there, it'll be all the way to the left. So what we're going to do is we're going to take this histogram, and the computer is going to go in, and because our technologists are awesome, you guys will always set the collimators in to the field of view. So you'll crop the field of view. You only want to image the anatomy that the radiologist needs to look at. And what the system will do is it'll automatically detect where those collimators are, and it will remove these pixels. These pixels right here are outside of the field of view of interest. And so by doing good collimation, you remove all of those pixels. If you do not collimate, if you just keep your field of view wide open, the system will then have to process all of these pixels too, and it changes the contrast in the image. So this is why collimation is really good. It cleans up our histogram. All right. The next thing, and I should comment, some people will, if they're really in a hurry and it's not a good practice, is they'll acquire the image, full field of view open, so no collimation, and then they will electronically add shutters. So they will just physically go in and remove these values. So when the radiologist sees it, they'll only see it like this. But the problem is because you didn't collimate, the computer doesn't actually know to remove this. The computer will actually have to process all of this data right here, and that will cause problems, as I'll explain in a minute. So now that we've got them all ready, we've looked at the histogram, we need to process that histogram to calculate the actual anatomy. So if each histogram, once it's been collimated, or we've looked at it and we've got only the relevant pixels that we want to image, if each of these regions in the histogram represent portions of the body, then the system knows how to map that. And so like I said, the chest radiograph will look one way, a knee radiograph will look another way. These values, these regions in the histogram that represent portions of the anatomy, these are called values of interest. So in a chest radiograph, our value of interest, of course, is going to be the lung parenchyma. And so we really want to focus on getting this data right here in this C region to be really good. Now it might be a different value here for a knee. In this case, the value of interest might be centered over the bone. So in this case, we'd want to get this portion of the histogram right. Nonetheless, whatever value of interest, whatever part of the anatomy is the most important in the image, we will set up a function to reconstruct the image so the image looks a specific way based on that value of interest. This is called an auto-ranging function. And so what it's going to do is it's going to set this function based on the way we want the value of interest, in our case, in this example, lung material, to appear. It's going to find, based on this function, based on this blue curve, it's going to find the maximum value and the minimum value in the histogram, and it's going to map that to the black and white respectively. Now, these VOI curves are very specific to the type of anatomy. So that's why it's very important. The first thing the technologists do when they pull up the patient from the work list is they go, oh, it's a chest radiograph. So they click on the chest patient anatomy. Now, if it's a chest radiograph and they click on the knee, well, guess what? The machine, if you just told it it's a knee, even though you're acquiring the image as a chest, the actual anatomy is a chest, The machine thinks the histogram is going to look this way, but the reality is the histogram is going to look this way. It's going to be really confused. And it's because these auto-ranging functions are very specific to each anatomy. And once we know what the minimum and the max is, it will then go through and it will apply all along this function. It will apply the values that it has set between the white and black. So in this case, for example, this yellow line represents these pixel values. This peak right here, as you may recall, this B value is a soft tissue. So it maps the soft tissue values to this grayscale right here. That is why this soft tissue in this image is this color gray. And the same for the lungs. Over here, lungs, or right here in this region is going to look somewhere in this little bit lighter region right here. And then some of the values up here, which is probably going to be more, actually this is more probably like your ribs, and this is more like your lungs, and the lungs can be a little bit blacker. I said that backwards. But nonetheless, all my point is each value along this histogram, every one of these values is going to be mapped to a different gray and white scale. Now, you might ask yourself, why does the curve look this way? Is this sigmoidal? It's got a shoulder where it's flat at the top and flat at the bottom. Well, that's based on values that were developed due to the olden days when we actually used film. And film, like any type of film, either camera film, photographic film, or X-ray radiographic film, it will process a very specific way based on the chemicals you're using. And the way that the types of chemicals and all of the processing that we used, the output will always have some kind of base and shoulder where the image would saturate, and everything in between would be somewhat linear. And so when we moved from film to digital, we just tried to mimic that curve. We don't have to actually use curves that look like that, but we do it that way just because that's how radiologists have looked at images from the beginning of time, the beginning of radiology. Now, these curves will affect the overall sensitivity of the image. So if you're trying to get a less noisy image, one curve will look a certain way. If you're okay if it's more noisy, then the curve will be shifted a little bit. But don't worry too much about that. I probably should have just deleted that that slide altogether. But what the most important take-home message is if you pick the wrong anatomy, so if you walk in, you click knee accidentally, but you go and you image the chest, these mins and maxes and this function will not do it right. So you got to pick the right anatomy for the right imaging. And then, like I said, there's different ranging functions for all different anatomy. And here, I don't know if it'll present as well on your monitor, but here you can see on this system that we have, it's a Philips unit, you can go in and actually change that lookup, that actual function. And so you can see how it changes the overall grayscale presentation of the anatomy in this image. And it goes from what would probably be pretty good. More this FC is what we normally use for our chest. So it's a good balance between soft tissue, lung parenchyma, and bone. And if you use some of these other ones, it really accentuates the lung parenchyma, but it saturates the bone, etc. So when you're going in and if the image doesn't look quite right after you've acquired it, you could, of course, re-image the patient using more radiation. But really, probably the first step you should do is you should just maybe go over to your post-processing. If you got the Philips, you click on the little bean-like icon. You click on that, and then you have the ability to change maybe one of these processing algorithms. And that could potentially change the image without needing to add more radiation dose to the patient. All right, so these curves will set the level of contrast in the image. So that's why we're talking about this, how much image contrast we can set. And if we set the window level to a very low number, what's going to happen is it's going, obviously you get less contrast. If you set your window level to kind of a medium level, you get a nice medium, probably good contrast. And if you set the level too high, it's focusing the reconstruction on the higher end of that scale, which basically shifts everything more towards the blacks. So setting your proper window level when you reconstruct is very important because it will change how the image looks based on simply that number, that level value you set. And this is also why, you know, the radiologists, they'll use their mouse and they'll click on it and they'll move up the level. They can shift the level. And as they shift the level, what they're doing is they're moving up and down this curve. So once again, if you have picked a knee, but acquired it on a chest, they'll be moving up and down this curve, but they'll be moving up and down the wrong curve. And so they'll never, in the reading room, be able to use their mouse to actually make the image look better because it's the wrong curve. So another major reason why you got to get the right curve. Now, the other option, there's the window level, and then the next one is the window width. So what we can do now is for a narrow window, obviously it's going to be focused on a certain portion of the grayscale. Wider gets more, allows more pixels in, and then of course the widest is going to have take on more of a kind of a uniform grayscale. So the window level adjusts the contrast. Window width adjusts the brightness of the image because you're just obviously allowing more values into the reconstructed image. Okay, so moving on, we'll talk a lot more about this, I think, next week when we talk radiation. But when we tell the system we're imaging either a chest or a C-spine, the system is now going to look for that anatomy. And so if you're imaging and for whatever reason the image just comes across and it looks horrible, most of the systems you can then click on it and it'll tell you what it thinks is the VOI or the anatomy of interest. And in this case, you can see how the system is confused and it's thinking the value of interest here is basically in the skin line. And that is why everything is just very low contrast, very general grayish, washed out image. Here, I simply took and I adjusted it and I told the system manually, I said, no, my value of interest or my anatomy of interest is the bony material. And so you can see how the green area is now more focused on the appropriate area of, anatomy. And then you can actually see better penetration through the shoulders. And now the spines feel better. Now, I'm not saying that's the best. You could slide that back and forth to try to find the best compromise between soft tissue and bony anatomy and penetration through the shoulders. But most softwares, most vendors will allow you to see what the image is reconstructing as the value of interest. And in all systems, there's almost always just one value. Excuse me, not all systems, all anatomy types, there's always one value of interest. Chest, it's going to be lungs. You know, most bony anatomy, obviously, it's the bone. Obviously, in the abdomen, it's going to be soft tissue. So you want to make sure that it's correct for what you're imaging. So now that we've kind of stepped through, we've taken the histogram, we have applied a few curves to it, and the image is now moving on to what's called forward presentation. It actually physically looks like the image that you are normally used to seeing in radiology. Now, those, like I said, I'll talk about this more next week. I'm going to just kind of skip over this, but these values of interest, the points along this image, that is where the system calculates the radiation dose. So whenever you see the radiation dose or the exposure index, the EI value listed in your radiograph, so it's usually on your screen. When the radiologist is reading it, there might be a value somewhere on the screen that'll say EI of 200, 400, 700, whatever. That's representing the amount of radiation that has penetrated through these portions of the body, and only the portions of the VOI, not the entire anatomy. So that's why EI is not patient specific. We did do so as physicists, we came up with a new way to represent this called the deviation index. And I'll talk about that more next week. But I just really wanted to point that out here just because this VOI affects the image quality, but also it affects the dose calculation that we use. All right, so we'll talk about EI and DI next week. So that is, in a nutshell, how to reconstruct your images. And as I tried to do it, I stepped through every step of the reconstruction process, why it's important to get the patient centered, why you got to get them collimated. You've got to already have done all the right things, get the right KV, the right MA, the right distance, you got the grid in. All of those steps are very important to get the right quality image. But then you have to push the right buttons on the reconstruction algorithm so that you get the right image to the radiologist. It's a big process to optimize all of your x-rays. So I guess we can go for questions now, or if there's general questions, we can take them now, or we could also talk about the COVID imaging, and we could do maybe one big question and answer at the end where we tie this both together. So whatever you'd like to do, Tanya.
Let me see if we have any questions from the audience in chat box. Seems like we don't have anything right now. I have one question, Sam, because I just took the exam, the CAQ in the pediatric radiology, and one question from my exam is about the abdominal radiograph, and they ask about why we should do like what the imaging technique that we should do, like a high KV or low KV compared to the chest radiograph, and why we need to do that KV. So which means I should attend your lectures before. I should listen to this lecture before the exam, because you explain about like a high KV and low KV for like the bone resolution, the bone soft tissue resolution, and those stuff.
That's very. I mean, that's a lot of people don't quite know why chest X-ray is a high KV, because it sounds opposite, right? Chest is long. So you would think you wouldn't need as much radiation, but it's not that we're worried about that. It's where we're trying to actually remove as much of the bony signal in the image, so you, the radiologist, can see through it to the lung anatomy.
Yeah. So which means chest X-ray should be the high KV and abdominal should be the low KV.
I would say low to medium. You know, you're in your 70, 80, maybe 90 kV. The low KVs, 40s for your hand, 50s hand and arm, 50s, 60s. Now you're getting into your shoulders and your legs, but the abdomen, just, obviously it's kind of big, it can be thick. And so you're probably in the 70, 80 range.
70, but for chest, it should be like a 120. 120.
Probably about somewhere in the 100, 110. As kind of the low end, and then you could go all the way up to 120, maybe even 130 if you have a relatively large chest, like a big patient.
I see. So that's why I should listen to your lectures before I go to the exam.
Looks like Hong has a question here.
Yes. Yep. So is the parallel grid easier to use than the focused grid?
So the answer is, there are grids out there that most grids will have a focus to them. So there's always going to be some type of focus. There aren't really perfectly parallel grids. Now, in short distances, such as like in mammography, there are some parallel grids, but for the most part, even chest radiograph, in X-ray imaging, because we're at least 100 some centimeters for the abdomen, and extended, we're 130, 140 and more for the chest, then there's always going to be a focal distance. And that is why you have to use the grid for chest imaging for the extended SIDs, and then the grid for the abdomen or the table imaging for the short or the lower, the shorter distance ones. And if you don't, you will cut off your images. So one of the dirty secrets is with digital imaging, we went through all of these. Here we go. We went through all of these steps right here. We can do a lot of manipulation to kind of erase some of the things like grid cutoff, or if we have the wrong KV, let's say we shot the abdomen at 120 kV. So now the histogram is shifted. The reality is we can actually go in and kind of manipulate it to make it look as good as possible and overcome some of these deficiencies. So that's why the thing we teach our technologists is if you acquired the image and it just doesn't look right, the first thing you do is try to manipulate it a little bit. And if you can make it look good, then you don't need to re-expose your patient. You can just send it to the radiologist. That said, if you acquire like an arm at 120 kV, you're just going to blow it out. So it doesn't matter how much manipulation you do on the histogram, you won't fix it. And the same with the grid. If you accidentally pick the wrong grid, you may be able to adjust it a little bit and it'd be okay. But if you use a table grid for say 100 centimeter focal, but you're imaging, let's say you're imaging a scoli, which is very far out. It's farther than the chest because it has to do, the whole vertebral body. Then there's no amount of adjusting is going to fix that. The image is not going to look real good.
And so another question is, does it mean do we need to use grid in almost every body part? Or it depends again, because I know that for the children, sometimes we don't use it in the fluoroscopy, right? But for the radiograph.
Yeah, and that's a great question. And I didn't really focus on that. I guess I probably should have put one slide on that since I was thinking more COVID, which we'll talk about in a moment. But in chest and abdomen, yes. For most patients, even for kids, you're going to use a grid. For the littlest to teeniest of patients, littlest of babies, you don't need to use a grid. And that's just because there's not that much scatter. The kids are teeny. We'll talk about it next week about the radiation dose. Obviously, when I said when you put the grid in, you are immediately covering about 30% of the anatomy. So therefore, you have to increase the dose by about that much so that you can get more photons through. Therefore, if you put a grid in and you put a teeny little baby that doesn't cause a lot of scatter, all you've done is increase the dose to that baby. But for most people outside of, a 1-2-year-old on up, you're using a grid for everything: chest, abdomen, pelvis. For the extremities, for arms and lower legs, no. Extremities, obviously through pelvis or shoulder, yes. It's a lot of material. So you have to use your judgment. If there's going to be a lot of scatter that can happen, then you're going to want a grid. And that's also the same for mobile imaging. I know it's a lot easier to not worry about a grid because when you're in a fixed room and you slide the detector and the grid into the table, the system has already got it so that the radiation is lined up perpendicular. So when you change your angles, the system is smart enough to figure that out. But a mobile unit's not. And so if you take a detector and you put a grid on it, now you go slide it behind someone's back and they're sitting at a kind of weird angle and you don't compensate with with the x-ray tube, then you can have potential for grid cutoff. And so there are some people that I'm not saying that they do this on. It's just some people will start to remove the grid because it's just easier to image without the grid. But when you image without the grid, and I'll slide all the way back here. When we image without the grid, as you know, as I showed, I'll stop right here. You will get images that will look just a little bit more hazy. Now, if you're doing a mobile and all you're doing is looking for a PIC line or just a line placement, if you can see the line, then maybe it's okay. But if you're looking for more, if you're trying to find a fracture or something, I don't know why you would, but if you were looking for just a small piece of detail, then grids really help because as you can see, the image on the right versus the image on the left is just different. And that's why we want to use grids.
I see. สวัสดีค่ะอาจารย์ปานอาจารย์มีคอมเมนต์เพิ่มเติมไหมคะ
อันในนั้นตอบหมดแล้วเหรอคะ
ยังค่ะยังเหลืออีกคำถามหนึ่งค่ะอาจารย์
ไม่เป็นไรให้อ่านทางนั้นก่อนดีกว่า
Okay, Sam, there is one more question about what is the better exposure factor sitting choice of practice in case that we have to do the mobile chest X-ray procedure without anti-scatter grid, because that anti-scatter grid is quite heavy. And most of the, I mean, I can say like maybe 80% of our technologists are female, like a very small female to carry that heavy grids. So
yeah, my one of my very good friends back in when we were going to grad school, she's from China, so she's this very petite young little lady. And when we would go to do all of our testing for physicists, I mentioned, and there's some of those phantoms are 70, 80 pounds. I mean, they're like, we're talking many, what is that, 40-ish kilos. This poor little girl, she was trying to move these around. So I understand that because the grids can be very heavy, especially for portable grids. Here, let's go back. These type of grids, right, where are you, portable? These guys right here, these clip-ons, tend to be heavy. And the unfortunate truth is, because they're heavy, people don't use them. The other option is there are actually very lightweight grids out there. For example, I know when I was there and I went around with Dr. Panutai, she showed me some of the GE portables you guys had at one of your hospitals. I know you don't all have GE portables, but GE has very lightweight carbon fiber. And so the first thing I did when I worked at my last place, we used all of these really heavy lead scatter grid, these anti-scatter grids, and the technologists never used them because they were just really heavy. And you drop one of those on your toes and that's the end of your day. And so the first thing I says, well, if you have the money, I highly recommend you buy lighter weight grids. Now the lighter weight grids will not, of course, have the same quality. Obviously a little bit more scatter is going to get through of it because it's made out of plastic, not lead. That said, it's still better than nothing. And so if you can replace the heavy ones, get the lighter grids, that's a good thing. If you take the grid off and you use it without a grid, the reality is if you could compensate by reducing your MA a little bit, but remember this ratio. Oh heavens, I don't even know which direction I should go. This ratio right here, if you lower your MA, that's fine. You're reducing the amount of primaries, but you're reducing your scatters. And so you're actually reducing them together, if that makes sense. So you're not reducing just the scatter and maintaining primary, you're reducing them both. And so the overall signal actually will go down. And now if you change your KV and you go say higher, then you have the potential for more scatter. So now your S will go up and your primary may go up, but not as fast. If you change it to a lower KV, you're going to get a lot more absorption in the bones, which is a good thing. So now the bone will stick out a little bit more. But if it's a big body, then very few of the photons are going to get through. So even though you'll have a little less scatter because you get more absorption, you'll actually have a lot less primary because the photons are just not getting through the body. So that's just, it's the hard reality of trying to get the right photons through and reduce the amount of scatter. And that is why we use anti-scatter grids. That's the only thing that's really effective at, I think I gave a statistic. Is it right there? Nope. Sorry, this is probably all blurry to your eyes. There we go. Here's the statistic. That's what we're trying to do is we're trying to maximize the 50 to 75% primary and reduce the amount of scatter to 5 to 20%. The only way we can do this effectively is with a scatter grid. Like I just mentioned, there's really little you can do with MA and KV. Now, if you're lucky enough to have more modern soft technology, I know Philips has it. I think Carestream is moving this direction. I know GE is moving this way. I can't speak for Siemens. I can't speak for, I think, what's the company? They're in Korea. They're moving this way too.
Canon.
Canon. It's what's the phone? Not Apple, but
Samsung.
Samsung. There you go. Thank you. Samsung. They have their own portables. They also have this virtual grid technology, and this stuff right here. So if you have newer technology, if you have it, you will get to the point where you don't have to worry. So all these small petite radiation technologists, they don't have to worry about lugging these dumb grids around until we get to that
which
point.
means like eventually we need grids. It's like a physical grid or virtual grid, but both of them gonna help improve image quality.
Yes.
Right. So which means you highly recommend that we should have some kind of grid.
Yes.
When we X-ray the patient.
The only other thing I can say is if you acquire the image, just looking at these examples here, and if your radiologists are okay with the image on the left.
No, we are high maintenance people.
Yes, I know you're high maintenance. Right?
We are really high maintenance. We want to see everything.
Yes. So if the radiologist is okay with the lower quality image, then don't use the grid. But it's been my experience that, they have a hard time seeing the exact line placement. I mean, here you can't even really see. I know this image is cut in half, but imagine this white going all the way over through the stomach. I mean, could you see where the line placement is? And would the radiologist be able to say no? And so that's why, generally speaking, I hate to say it, even though those grids are real heavy, you have to use them. And if they are just not good to use, I hope they can work with the hospital and the hospital can buy lighter weight ones. They are there and they are not that expensive. So you should be able to, now if you have 100 mobile units, then it might get expensive. But yeah.
Sure. Okay. Ajahn Pani.
Sam, you talk about the post-processing, the 5 steps, and I think the 5 steps occur before archiving, right? Before sending for the archiving system, and how about the electronic clipping done by the technologists, and at what step does it occur?
Yep.
And
so
they can do, because you said that if Y collimation affect the histogram, and can collimation is the collimation automatic, or the technician do it at the beginning?
Yes. And thank you for pointing. So if you set the KV right and you set your MA right, you get your patient aligned right, you got your scatter grid in right, you've done all those steps right, but you don't set your collimation right, then you kind of actually undo a lot of the good things you've done. Having really good collimation for the anatomy that you're imaging. So if it's chest, we want a good collimation. If it's a lateral head, as you see on this image, you want to get good lateral. You want to minimize how much air is in that image. And the reason is because if you have good collimation, physical collimation, so you've actually dialed in the physical collimator, so the light field and the collimations are all set. When the image comes across, the system knows that those pixels can go away. Because when you acquire an image, a raw image, this part of the image, of course, was directly exposed. And everything behind the collimator blades will look white like this. And so the system goes, oh, I know what's white. I know those are the collimator blades. So it immediately deletes all of these pixel values. And that is what allows the system to do all of this processing right here. And as you were mentioned, that if they do not collimate, so now it's full open and they image, so there's a lot of air around a lateral head, well, the system is going to have a lot more pixels of air, and it will not be able to delete those because there's no collimator blades to find and delete. And therefore, that curve you use to map your grayscale, this curve right here, it will be skewed. It will be different. And that is why it will come across, and the grayscales that you're normally used to in, say, a chest radiograph or the white that you see in the bony anatomy for a skull, they will be just off. And so a lot of people will, not a lot of people, some people, if they just don't want to take the time to collimate, they'll just use one big field of view, acquire the image, send the patient out, and then they will electronically collimate it. So the radiologist will actually see the image with proper collimation, and they'll think it was acquired that way. But the image itself, the grayscale, will be a little off. And as I mentioned, when you are setting your windows and your levels right here, so when the radiologist is using their mouse, that is when it will be the most evident. Because you, the radiologist, are trying to window and level, but because they didn't collimate, the system did not use the right curve. And so you're going up and down and left and right, and it's not getting blacker and whiter. It's just not looking right. So that is why it's very, very important to take the time to do the right KV, the right MA, get the right patient set up, get the right angle. All of those are very important, but also collimation. Now, the nice thing about, you also asked at the very beginning of your question, is that all of this happens at the console before they send it over to the PAC system. Now, if you, the radiologist, are looking at this on PAC and say, you know, this just doesn't look that good, you can call them up if you have the time and the ability, right? You can call them up and say, hey, something doesn't look right. Can you reprocess that? And so the first thing is if they accidentally, over here on this picture, they were supposed to, let's say, do a child's skull, but they clicked chest for some accident. It was just an accident. Well, they can undo that. That's easy. All you have to do is pull the image back up, and instead of chest, push skull, and it'll reprocess everything. And if it really was a skull, it'll look so much better. The second thing is if they picked the right anatomy, so it was, say, a skull, and they clicked skull. So the system is looking for skull, but things are just still not right. Maybe the patient didn't have as dense a skull, or there was just some kind of pathology or something going on that made the image not look so good. You can actually click on and change the type of reconstruction algorithm. It'll help the image maybe look a little bit better. Now, you just have to be careful because you don't want to obscure pathology. And so if you do that, if you make 2 or 3 looks or views, make sure you send them all, so the radiologist can see them and go, oh, okay, I can see the differences. Because if the technologist, keep twisting it and manipulating it and making it look as pretty as you think and send it, you may have changed the anatomy, maybe covered some pathology, and the radiologist will never know. But if you send maybe 2 or 3 different looks, if the radiologist asks for it, then they have the opportunity to see how it's changed. So this is what we actually, for the longest time, what would happen at our institution is we would acquire the image. It didn't look so good. So the technologist would call the radiologist and send the image to PACS. The radiologist would have to stop what they're doing, pull up the image and look at it and say, no, that doesn't look right. So they would process it and resend it. And it was just, it was so annoying. The poor radiologist, all through the day, they kept getting stopped and interrupted. So we finally said, no. What you need to do as a technologist, they're smart, they're intelligent people. If the patient just wasn't center right, the patient moved, okay, reshoot it. You just have to acquire a new image. If everything was acquired right and everything should be right, but it still doesn't look right, reprocess it and send both the images. And then we're not interrupting the radiologist can look at it. And if the radiologist says, I still don't like it, the technologist can always go back and reprocess it. The patient's gone, you can't reshoot them, but you can at least reprocess it. So that's what we do at our institution. We've given a lot of authority and control to the technologists who are, you're smart people.
So, okay, Sam, I have 2 more questions for you. One from the international audience, and I think he's gonna ask you by himself. Let me unmute him.
Mm-hmm.
Pong, he raised his hand. Hold on. Pong Dang, can you?
Hello?
Yes.
I have a question for you.
Mm-hmm.
Okay.
Yes, we can hear you.
Sorry for the introduction. My name is Phong. I'm a teaching assistant and a technologist in Medical University in Ho Chi Minh City, Vietnam.
Okay, wonderful.
Okay, I have a question about the grid. So when we put the detector into the table or the stand bucket, and then we tilt the tube to a certain degree, does it affect the quality of the image? Because the grid is fixed, it's not tilted to the same degree of the tubes.
Yeah, that's a great question. So if the detector is in the table and the patient is on the table and we tilt this way, the x-ray tube, now it's not perpendicular and it's not more specifically, it's not aligned with the grid. And so the answer is yes, it can affect that. So typically, as an example, let's say you're doing a knee image, right? You're doing a sunrise. So you're going down through the kneecap. That is why typically we'll have them take the detector out of the bucky and they'll hold it to their knees and then you'll image at that angle. And so I know there's all kinds of angles that you're imaging as technologists. And the way that when you have to get really strong angles, really distinct angles, you almost always have to take and get that detector out and move it with the tube. In a perfect world, you will always align the X-ray beam perpendicular with the tube, with the detector. That's not perfect. And so if you have the table, if you have the detector in the table and you need to maybe make a very small angle change, it's probably not going to be that big of a deal. Small angle. But you start to make very large angles, then because the grid is expecting a perpendicular beam and it's coming in at an angle, then you get this effect. Whoa, it disappeared. Sorry about that. Let's get that back up. All right. Okay. Here, I'm going to do this so you don't have to watch me scroll through. Can you see my screen still?
Yes.
Perfect. Oops. There we go. Right here. And so what he's basically asking is if you actually, in this example right here, the detector is off angle, not the tube. But now if you take the table, but you make the tube off angle, you get this effect. For small angles, it will probably not be too bad. But for large angles, it will cut off.
Mm-hmm.
If you're doing film, if some people are still doing film will show this a lot more than digital. Digital, like I said, you can kind of adjust that to fix that. So yes, do your best to keep it perpendicular to the detector.
Okay. So hope that answer. Yeah.
Okay. I
hope that answer his question. So there is one more question before we move on to the COVID lectures. So the last question is like what is the histogram when we do the chest with abdomen in children? Which histogram do we choose? And so the real question is what the difference of the histogram patterns between chest alone and chest include abdomen in children with and without the proper collimations, and which DICOM header track that can help us to check the real field of view.
Sure. All right. Those are great questions. So let me come back to, let's go back to this slide right here. So the first thing, actually the very first question is a chest histogram will largely be the same for adults and children. Now, when you get to be teeny, obviously the overall histogram will be smaller, but I mean, assuming normal pathology, right? So we got 2 lungs, and then of course we got our normal bony anatomy, bony structure. Even if it's smaller, assuming you've also collimated smaller, this histogram will largely be the same. Now, obviously, women will present with breast tissue, and if they have denser breasts, or, you know, depending on the age, the breast tissue may be located slightly differently. That will add a little bit different to it, but the major structure of the histogram will be the same. Now remember, in the chest radiograph, obviously we're most concerned about the lung fields. So we're looking at kind of this region right here in the histogram. And so for the most part, that is always the same. And obviously, just as an example, you can see these two histograms are very different. And so obviously an abdomen would be different than a chest, but kids to adults are largely the same. If you go in, some vendors will have, where did my vendor picture go? They will have different options right here. So you will have maybe like a kid's chest versus an adult chest. And part of that is because kid chest will not have the potential for breast anatomy, whereas obviously adult chest will have that potential. So there may be slight differences. If your system has chest for pediatrics or chest for kids and chest for adults, make sure you make those two distinctions. Basically from adolescence on, from teenagers on, you should probably be just picking the adult because they're, you know, teenagers are just kind of small adults. The other question that you had was, how would the histogram change if you're not collimating properly? So if you have a lot of air, you're going to have, so actually let me go back. So air, you see D right here, that's over here on this side of this histogram. So if you did not collimate, in this case, whoop, where'd it go? Oh, I know why. There you go. I hit it. If you did not collimate, you're going to have a lot of air out here. So actually this white is the collimator blades. In reality, it would be black, right? It would actually look like this because it's all air. And that means this side of the histogram would be big. You would have a lot of pixels there. It might be taller or it might be a little bit wider, but there would be a lot of pixels right here. Additionally, this part of your histogram would not go away because we wouldn't be able to cut out any of the excess. And so how does that affect? That it affects it when you're setting the minimum and the maximum. So right here. So based on the shape of this histogram, we know where the minimum is and we know where the maximum is. And so we set this blue curve, this blue line, this value of interest based on the minimum and the maximum. So if there is a lot more black in the image, this curve will be shifted. And because it'll be shifted, then when it goes to map these gray values, this value right here for soft tissue that would normally be this grayscale color right here might actually be shifted up, or it might be shifted down depending on how that curve is shifted. So it might actually appear whiter or blacker. And so that's why, like I said, if you don't collimate, even though you still put the shutters in, so the radiologist only ever sees the anatomy that it was meant to see, the algorithm is looking at everything, all the pixels. And so the image might not look just right to the radiologist. So do your best, because every anatomy button on your machine will have different prescribed minimums and maximums, because it's looking for that specific shaped histogram. So just good technology. Good technologists have been trained in good technique. And so if they just stay with that, then they'll get the best images possible.
Okay. Thank you so much, Sam. We have a lot of very productive questions.
Yeah. Good night's almost over. Should we just call it good?
Yes. Yeah. So we're gonna move on to the COVID things, which is like a big issue right now, and radiologists and technologists get involved a lot as a part of the care team. So we want to learn how to adjust the imaging technique, get a proper image quality to get the correct diagnosis to the patient from you.
All right. I assume you can see my screen now?
Yes.
Perfect. Off we go then. So everything I just said, throw it out the window, right? We're now imaging in the most unideal circumstance possible. We're not bringing the patients to us in radiology. We're not putting them on a table. We're not putting them standing up against a wall bucky. So the grids are not going to be perfectly aligned. Our technique factors aren't going to be the same. We just have to work with what we've got. So this is where both the technologists have to do their best to get the best image, and radiologists have to be the most flexible to look at images that just aren't really going to be that ideal. So what are the goals here? Well, actually, let me step back. What are we basically doing? We're doing mobile imaging, right? So these are patients that are sick. They're in the ICU. They're potentially not in a place where, even if they weren't that sick, you still don't want to bring them to the other part of the hospital where they could potentially infect the staff or any of the other patients in a different part of the hospital. So we are going to be imaging in a very unique location. Oftentimes these patients are in isolation, especially if they're in the COVID ward. And the patients may or may not be able to move. They may not be ambulatory, or they may not be able to even speak. They may be intubated. And so we might not be able to give them communication, talk to them, like taking a deep breath and hold. All of the stuff that we typically do in radiology, in our main part of radiology, we will have to adjust. And then, of course, unfortunately, we're dealing with a lot of sick people right now. And so we're talking about space being limited. You've seen a lot of the news coming out of India, where, I mean, it's not only are they so busy, it's that they're maybe sharing beds. You might be going to image someone and there might be two people in that bed. And so highly in the most unoptimal situation possible. So what are the goals of imaging for COVID? To create the best possible image for the best possible patient care. We understand that, right? 2, we need to stay operational. You, the technologist, can't get sick and go home and have COVID. We don't want that. And 2, we can't contaminate our mobile unit, our detector, because if it gets contaminated, then we can't take it to the next patient because now it's a hazard. So we got to keep you safe, keep the machine safe, keep the detector safe. And then obviously we need to be flexible. So why do we image COVID patients? It's often been asked, especially when it all started. We immediately saw people taking x-rays and CT scans, and we could see the ground glass. We could see the opacification, the pneumonia-like look in the images. But the reality is that imaging is actually not recommended for the diagnosis of COVID. And that is just because COVID pneumonia looks like basically all other pneumonia. In fact, CT and X-ray, neither of them have shown to be any more specific for COVID. And a publication that came out, of course, in 2020, there's a lot of publications that have been looking at this. They looked at what was that cruise ship? The Crown Princess, I think, that was out, and it was one of the first that COVID got there, and I think 112 patients were COVID positive on that cruise ship. No, actually, I think there were more. There was many more, but 112 of them got CT scans. 61% had lung opacifications, so they had kind of that ground glass, that pneumonia-like look. 20% had negative CTs, absolutely clean-looking lungs, but they were symptomatic with COVID. And so the take-home message from this was that imaging wasn't specific enough to determine that this test could diagnose COVID or rule out COVID. So why do we image? We image mostly for the management of patient disease. So we're looking for progression. We're looking for potentially all the other comorbidities and side effects that come with COVID. And so we have to be we're not necessarily just imaging for pneumonia. We're actually also imaging for line placement. We're imaging for a lot of other things. So yeah, there we go. That's what I read. Okay, well, I'm sure you've seen these by now. If you haven't seen them in the literature, you've unfortunately probably seen them on some of your patients. So what does COVID look like? Well, it looks basically like pneumonia. You got disease progression where you got fluid buildup in the lung parenchyma, and this just becomes with time more attenuating. When you got fluid in there, it's not air. So you get more photons that'll attenuate. And so you got this fluid-like or attenuation-like patterns throughout the chest. So what is the goal? As I mentioned, we're trying to do our best to help the patients get the best images for our radiologist so they can work with their colleagues in the ER or in the ICU. But the reality is we can't get you, the technologist, and the machine exposed. So one technique that was developed very early on is what we call image through protocols. We are going to quite literally image through glass doors. We're going to image through doors with teeny little glass openings. We're going to image through whatever we can image through, right? If we're lucky, we might image through an open door in a negative pressure room. So, and this is probably the most ideal situation because you're not actually going through glass, but it's not ideal because you're still shooting outside. You're in the ante room, you're over here, whereas the patient's in the negative room, in the actual room where the negative pressure is. It's obviously allowed to have an open door because it's a negative pressure, so the air is only flowing into the patient's room and not out to you. So those are kind of the three major areas or three major geometries in which we're going to image. So let's talk about the patients for a moment. How can we image them if they are ambulatory? So they can get up, they can move around, and obviously that means they're not intubated. And that means we can most likely talk to them. So what we're going to have them do is we're going to have them stand up. Sorry, it's rolling the wrong direction. I'm going to have them stand up. They're going to come to the door. So we're going to image through the door. We're going to have them turn around. So we do a nice typical PA acquisition. And we're going to have them hold the detector. So no chest bucky in the room. They themselves are the chest bucky. And we're going to do our best to get that detector lined up to the chest anatomy. The other option is wheelchair bound. So they're still, maybe they're not intubated, so they still can maybe communicate. But obviously they've progressed enough in their disease, or they physically themselves just cannot stand because maybe they already are physically disabled. So they're in a wheelchair. In this case now, we're going to move the wheelchair once again to the door. We're going to get it close to the door where they'll be seated upright, and we can put the detector directly behind them, between them and the wheelchair, and we can acquire the image. And then in the worst case scenario, these patients are going to be confined to a bed, potentially intubated, and so you will physically have to take the machine into the room. There is just no other way to get in and position it and image down over the patient while they're laying on the table, on the bed. So the first two, as I mentioned, we're going to be imaging through a door. The other one, we're going to be imaging like you always image mobile units. So we do not need to make any we don't have to make many modifications for the last option. Okay, so let's go through these in a practical sense. So one of the best things you can do is you're going to be working closely with the other staff that are in the room. So this is the scenario where you are not going in the room. You're going to have to help instruct the nurse or whoever else, the support staff that's in there working with the patient. So the first thing you're going to do is you're going to take your detector and you're going to cover it in a sterile bag. Some publications, such as the one I quoted here, they actually covered it in 2 bags, just in case the first one got accidentally perforated. That's just, you want to minimize how much this detector is going to be directly exposed to a COVID environment. And that helps you, and as I'll explain in a minute, that prevents you from using a lot of harsh chemicals to clean and sterilize your detector. So we're going to bag it, and then we're going to hand it through the door to the nursing staff or whoever else is in there. They're going to then, you're going to then work with them, and they're going to help give instructions to the patient so that they can come up to the door, and they're going to turn their backs to the door, and they're going to hold the detector to their chest, as I mentioned. Where, if it's possible, I highly recommend that you actually put markings on the tape on the floor. Now that's going to be difficult because if you put tape on the floor, your infection control group, you know, they're going to be cleaning those floors all the time. And that tape might get ripped up. If you physically mark on the door floor with like a physical marker or do anything permanent, well, it's going to be there forever unless they fix the floor. But the reason I say if you can put a marker on the floor is that we talked about having knowing where your distance is. And if you're shooting through a door, you can't actually take the measure. You know, you got the collimator, you can't take the measuring tape out and go check to see how far away they are. You can only guess. And so if they're staying at a mark on the floor that's set at, say, you know, 72 centimeters or, you know, not 72 centimeters, 72 inches. So, you know, about 140, 150 centimeters, then you know what technique to type in. And then you might need to put multiple markers on the floor because it's in a perfect situation, they can come up to the door. So you can keep your SID as short as possible. But if they just physically can't, or there's a lot of stuff in the way and they may be farther away, well, what is the source? What is your SID? You don't know. But if you have a couple of markers on the floor, you might at least be able to go, oh, they're about 200 centimeters away or 220 centimeters away. So you can make that guess and you can adjust your technique accordingly. All right. So if they're in the wheelchair, we already kind of talked about this. You can just place the detector behind them. And in most scenarios, they're probably going to be in a bed. Once again, they can be wheeled up to the door if possible. Detector, it's bagged, placed behind the patient. As much as possible, we're going to have them sit upright. The nursing staff will place it, but obviously the nursing staff will then step back. We don't want them holding the detector if they don't have to, because we don't want to be exposing them. All right. Now, we are imaging through something, so we have to change our technique. We have to image through glass, and we have to image through distance. We're changing the SID. So the SIDs can actually vary quite a bit, anywhere from 180 to potentially 500 centimeters in some publications I read. So you got to image across the room. That's crazy. You also need to know where you're aiming, right? And so for us, we have the collimators and we have the light fields. So we're going to need to be able to, whoops, not that button. My apologies. Sorry, I pushed the end button, not the next button. Okay, so we need to be able to see the collimator as it's projected on the patient so we can set our collimation as best as possible. And then we need to talk about grids. All right, so the technique factors. Normally, we're shooting, you know, Tanya and I, we just talked about this. Normally, you're shooting around 100 kV, about 2 to 4 mass when you got the machine right next to the patient. You're not shooting through glass. This is what we would do in an ideal situation in, say, a fixed room. So their patient's up against a chest bucky. This is kind of what you're shooting at. If you're in a mobile situation where the mobile goes into the room in a non-COVID environment, this is kind of what you're doing. So we need to modify that. You're going through glass. So we absolutely have to increase the kV. We have to penetrate that glass. And so you're going to start right around probably 120, 125. You may even have to go a little higher depending on if it's thicker or older glass. I just don't know what your hospital's like. Unfortunately, it might be a little bit of, you know, you might have to just trial and error that. If you have phantoms and stuff, maybe you could do some pre-testing, but this is probably happening in real time. So the first patient you wheel up to them, you're going to line it up and you're probably going to just change your KV up to 125. And if the image just doesn't look good, you might have to go up a little higher to 130. Now, like I said, some mobile units will actually have filtration in their physical filters. You can either physically take them out of the collimator, or there's a button that will remove the filtration in the collimator. I recommend taking all that filtration off. Turn it off, because the glass itself, the window, will be a filter for you. And so if you have a filter in with copper and aluminum plus glass, then you're really going to have to crank up your technique factor. And that's just not good. Obviously, it's more dose to the patient, but it's a lot more scatter for everyone else. So too much filtration will reduce contrast, and we talked all about that last time. Changes the KV, changes the mean spectrum energy, changes scatter. So typically what's out there in the literature, typically what you would use is somewhere in the 120 to 130 range, and you're probably going to be about 6 mass MAs in time. You might go a little higher, 7 or 8, depending on the size of the patient and your distance. This is if you can get them up to the door. Now, if they are farther away from the door, the only thing you can do is increase your mass. Because remember, as you're imaging, as it goes away from distance, 1 over the distance squared, your photons are changing with 1 over distance squared. So you're getting less and less as the distance gets farther and farther away. So you have to compensate by increasing it by a couple of steps. So there's a couple more things. And now, this was the question that was asked a little bit ago from our friend in Vietnam. He mentioned that what happens if we tilt it a little bit? Well, I said, do your best to keep the detector and the radiation beam perpendicular. Well, like I said, that's a perfect scenario. In this case, this door has a very small glass window, and a patient is not going to be that tall. At best, if they're standing, they're going to be shorter, so you're going to still have to come at an angle. At worst, they're going to be sitting in a table or on a stretcher, or they're going to be in a wheelchair. And so your angles now are not perpendicular. You're coming in at this weird angle. And because of that crazy angle, what can you do? There is nothing you can do. So your images will be off angle. So what does that mean? That means the anatomy will be distorted in the image. It's very helpful if you maybe make a comment on that to the radiologist, so they just know that image was at angled high or something. So they know that they're basically looking down at the anatomy, not straight onto the anatomy. Those are all things I already said. Oh, this is actually a good point I should make. So when you're imaging through the glass, you, as I mentioned, in a typical situation, you might be 8 mass or so. You might go as high as 10 or 12 mass. The problem with these portable systems is you actually don't have that many MA options. You know, you might be able to dial in 1.2, 2, 2.5, 3, 3.54, 5, 6, 8. So as you get higher in MA, the options become fewer and fewer in between. There's bigger jumps. So therefore, if you want to go from 8 MA to 12 MA, you actually might not have that option. And so what the system does is it increases the amount of time the machine is on. So you still can get a 12 mass, but you won't get a 12 MA. You'll actually get maybe like a 8 MA for that much longer of time, if that makes sense. So the problem with that is the longer the beam is on, there is a lot of obviously motion going on. They probably can't hold their breath. If they can hold their breath, that's great. But if they can't, there's involuntary motion. You got cardiac motion, you got lung motion. If the people are sick and they can't stand as well, or if they're, you know, even if you sit here perfectly for a minute or two, you'll just kind of fidget. People just don't normally sit still for a very long time. And so the longer the exposure time, the greater chance for motion artifacts. And unfortunately, once I get it said, there's just not a lot we can do about that. So The other thing to talk about is being able to set the field of view. So we just talked about getting the right collimation, right? Well, you need to make sure you at least get the right anatomy. The right anatomy is the lung field. And so what we're going to do is you need to set the lights prop as best as you can. And so if you can't, when you turn on your collimator and you start adjusting it, it's projecting through the glass onto the patient, you may need to ask them to turn off the room lights so you can get a very good idea so you can set it. Worst case scenario, if you just can't turn off the lights and you're in these really high bright light interventional rooms, then what you'll have to do is just open up your field of view. And that is why a lot of the COVID images they have your lungs, they got the lungs, and that's good, but they might include a lot more of the human anatomy. It is what it is. So the image quality will come across. It won't be nicely mapped. The blacks, the whites, the grayscales, they won't be as nicely mapped, but it is what it is. Now, I mentioned grids. We want to use grids as much as possible. But if you're coming in at weird angles, the grids potentially are going to clip the data. And you don't want the data, you don't want the anatomy to be clipped because it will burn out, the lung fields, or you'll lose some of the imaging along the periphery of it. So, and then I guess the other thing to consider, especially if you got a heavy grid and you, the technologist, struggle with that, you're not going to be able to get a patient to hold a heavy grid either. They'll hunch over, especially if they're sick. So there are real examples of when you probably will not be able to use a grid. In a perfect world, you will still do your best to get the tube as aligned as possible to use the grid because you'll get better image quality. But if you cannot guarantee that it'll be a good perpendicular, or if the grid won't really stay attached, once you put it in the bag and there's the potential for the grid to come unseated from the detector, or if the patient themselves has to hold it and it's hard for them to hold it, then you're just not going to be able to use a grid. Now, if you are going into the room and placing it under the bed, under the patient, then you can still do a grid. If they're sitting in a wheelchair and you're putting it behind their back, you could probably use a grid as long as you can get that as well positioned as possible. So do your best with the grids. So let's talk about how we've really talked a lot about the negatives here, right? We've talked about how we have to increase our KV to get through the glass. We've talked about how we've got extended SIDs, but there's actually some positives in this. First of all, we have to increase KV, but because we're imaging through glass, the glass is a filter. And so the dose to the patient actually hasn't changed that much as we've done the calculations. And so don't worry too much, because yes, you've just doubled, maybe tripled your technique that you're normally used to. And that might be scary to some technologists. But understand that A, you're still doing this for their benefit. So even if it is a little more dose, that's okay. But two, most of that dose is getting absorbed in the glass, so it's not too bad. Now, the beam, when you are super far away, the farther you get out, obviously the beam keeps diverging. But when you get all the way out and you collimate in, long SIDs make the beam more parallel. In other words, the divergence, really, the farther away you get, it's more straight on into the patient. And so this is actually a good thing. It helps reduce a lot of the geometric distortion, and it can help reduce the dose to the patient. Remember, the intensity is now going to be more uniform across the field of view instead of that heel effect. The heel effect is largely gone at very long distances. So dose-wise, it's a good thing. And geometric distortion, so yes, you're imaging at weird angles, but the distance factor will also help so that the edges are going to be not as bad, and just the image quality will be slightly better in some ways. All right, and then because we are imaging through glass, which is a very strong filter, this has that effect of reducing the overall soft tissue bone contrast. And so it actually will help you see the lungs better because the ribs will somewhat dissolve into the background. So there are some positives if you can find them, if you can consider them that when you're imaging through glass doors in these crazy COVID situations. So what do we do about folks that are in the room that are assisting, the nurses and whatnot are helping? We need to help them feel comfortable being around radiation. So there's a couple of ways to do this. One, you can have them put on their normal lead aprons. You could hand them through. They would put the lead aprons on over all of their PPE. Then they can be in the room and feel comfortable. But when it's all said and done with and you need to take that back, it has to be completely cleaned. The other option is you can have a mobile unit, a mobile shield that you can just wheel into the room. You just put it in the corner, and this will be something you just take with you to all the different rooms. It obviously has to be sterilized after every use, but you could wheel it in. The nurse can help get the patient all set up, and when you're ready to beam on, they would just go stand behind the shield. So they don't have to worry about putting on or off lead. And if they have, the PAPRs and the respirators and all this other gear on them, because some of them are just, it looks like they're in a biological war zone, they might not actually be able to get lead aprons on. The worst case scenario is that the worst case thing you could do, if they can't put lead on, if you don't have a rolling shield, then they just need to get as far back as they can. So they get the patient aligned and they just step back as far away from the patient as they can, and they'll be okay. Scatter comes off the patient. We all know that, right? But remember, scatter tends to come back towards the X-ray tube. The X-ray tube sends the scatter, goes in, interacts with the patient. A lot of that scatter comes back towards the X-ray tube, and then some of it will scatter out laterally. And so if the nursing staff or anyone's in the room, if they just get all the way back and away from them, there's very little scatter will get to them. So nonetheless, all PPE that goes into those rooms have to come out and they have to be sterilized. Luckily, those lead aprons and these lead rolling, obviously they're covered in plastic, so we can pretty much sterilize them without much of a deal. Now, what about you in the hallway? If you're imaging through glass, the glass is going to cause scatter. So the radiation beam goes through, yes, but there's going to get a lot of back scatter. So for you are going to need to be away. So step back as far as you can. Wear your lead. If this person just took this picture for the publication, so they weren't actually all leaded up. In fact, I don't even know. They may not wear lead, but for the most part, if you're standing within 2 meters, you should probably wear lead. If you can step back farther than that, you're probably okay. But get away from the X-ray tube because that's where all the scatter is going to come back. All right. The obvious benefit of imaging in this situation through a door where all of the individuals that are sick or infected are behind a glass door is that this system itself will not need to be sterilized as much. The sterilizing wipes and stuff that we've been using are very harsh. In fact, for us, having had to wipe down all of our portable detectors, we had to replace every one of our detectors because the cleaning solution actually corroded the battery and destroyed the battery on all of them. So that was a really expensive mistake. And that's why we bag everything now instead of just placing the detector directly in contact with the patient. Obviously, by imaging through protocols in a very busy situation where you're going from room to room to room, you don't have time to sterilize the machine and let it sit for 15, 20, 30 minutes. You have to be able to move and take the detector from room to room to room. And so imaging through with bags and stuff really helps you keep the equipment online longer. And then, of course, you being out there, if you're not going in and out of rooms, you don't have to take off and put on new PPE every time. And so it actually helps the hospital in general. So that PPE can be used for those people that do need to go into the room. All right, so we talked a little bit about motion. Due to increased exposure time for high mass techniques, there will be more involuntary motion on sharpness. That's just kind of part of it. We want to reduce the SID as much as possible, and this will help keep remember, when you got magnification effects if the patient's off away from the detector, and then the farther away you are, you're going to get that penumbral effect. And so you want to try to do your best to keep the detector as close to the patient as possible, and try to keep your SID as good as you can, the source to image distance roughly in that, 140, 150 to 180 centimeters, whatever that range is that you're imaging. Breath holds, can you do it? Probably not. If the patient can hold their breath, I mean, we know that it's very short. It's less than a second to acquire the image, but for some patients that might be an eternity. And so you may not get a good breath hold, but you do still want to get as much of a breath hold as possible, because obviously that expands the lung cavity. It puts air into the parenchyma, into the lung tissue, so you can actually get a nice, good image of the lung parenchyma instead of it being collapsed on itself, which makes it more dense, which makes it more white instead of black. Some patients are on ventilators, and so the nurse can, and in this case, you're going to be in the room imaging down. But in that case, the nurse can actually manually pause the breathing for a split second where you acquire your image, and then they can turn it back on. So you can actually get an artificial or a manual breath hold. So let's talk about artifacts that come from imaging through the glass. There are some glass windows that will have privacy barriers built into them, either shutters like these, or maybe white cloth blinds that'll come up and down. This is an example from this publication where theirs have basically collapsing shutters or blinds like you see here. Imaging through that, there's nothing you can do. But if the radiologist asks, now you know why there's these white lines through the patient, because those are the shutters or the blinds going through it. A lot of doors will have these metal meshes in them. The glass will have metal meshes in them. Those are fire hazard or protections for fire hazard, for fire safety. And when you image through them, of course, you're going to get these star artifacts, kind of pretty. Unfortunately, they cover up the patient's anatomy. The best thing you can do is get your X-ray tube as close to the window as possible. Put it almost in contact if you can. Because basically what you're doing is you're just trying to make those patterns bigger on the X-ray itself. And here you can see, this was two different patients, but the same window. One was where the X-ray tube was a little farther away. The other one was where it was almost in contact with the window. And you can see the artifacts are largely gone, if not just barely present. All right, so that is if you're imaging in still a hospital scenario where it's probably still ideal, or at least more ideal. There's a lot of these field hospitals being set up in gymnasiums and conference centers, big convention centers. Your parking lot of your hospital might have a big hospital tent in it. So how do we image in these situations? So radiation protection principles. The best we can do is try to still maintain about a 2-meter distance from the X-ray tube and the patient. So as you're imaging, that's where all the scatter's coming. As the radiation's coming out of the tube into the patient, and the patient is causing scatter out. So if we can create a safe buffer of about 2 or so meters, you're minimizing the amount of scatter that will be incident upon any of the other staff or patients there in that area. So for mobile X-ray units, we're going to maximize collimation. In these situations, usually if you're going, if we're in this kind of a situation where you're literally rolling from room to, or setup to setup to setup, they're not really rooms, you will actually not be shooting through anything. It's not an image through protocol. And because of that, you can set your lighting and your collimation very good, because you should be able to get pretty close and get within your normal techniques. So maximize, do your very best to collimate, because the better the collimation, remember, less scatter comes off. Obviously, everyone should wear lead. And then, as I said, if you can get people to step back or do your best, you'll minimize how much scatter will be incident upon everyone around you. Now, there are cases, and some of my colleagues in other hospitals, they did this, where they set up the tent, and there was one room basically for X-ray. And what it was a portable system set up, and the system was stationary. And they would bring the patients either on wheelchair or in their bed up to that location, up to a wall. They would image through, and then the patient would leave. So we're talking about a quote unquote fixed unit, even though it's a mobile system. So what you want to do is, first of all, you need to make sure the access to that room is controlled. Obviously, it's a radiation and producing equipment. You don't want anyone to walk in. You definitely don't want anyone to think they can acquire images. Only technologists should be doing this. So that's a safety issue. If you have the choice, you want to use plexiglass instead of glass. So use plastic for your barrier. Plexiglass does not attenuate radiation. Oh, there they are. I'm sorry, my slides are out of order. I'll go back to that last slide. Plexiglass doesn't have as high an attenuation profile as glass. So for the same KV, or for the same amount of photons to the detector, you can use a lower KV, or you could use a lower KV and a lower MA. So imaging through plastic, you won't necessarily need to dial it all the way up to 130 kV. You might only have to go up to 110, maybe 120, but your mass might not have to go up to 12. It could be maybe 8 or 6. So sorry, my slides are a little out of order there. Whoops. Okay, let's go back to my slide. There we go. So image through plastic if you're setting it up where you will be able to control your imaging environment. You may need to make sure you have a separate power supply for your portable. As people are coming and going, they have the overhead lights, they have all of the equipment, ventilators, whatever's going on in there. That might be a very taxing environment on the power supply. So it might be intermittent. It might have spikes and peaks and valleys. So if you could set up your own power supply, the portable scanner will actually perform better having its batteries fully charged and being able to consistently image. And then a 20 to 35 kilowatt generator would be more than enough to power your 10 kilowatt X-ray tube. You obviously need to set up a connection, a Wi-Fi connection or something, so you can get the images to PACS. Infinitely better than having to burn them a CD and walk across the street. Okay, yep, looks like that's everything. All right, so an unideal environment can still be, you can still operate because you are trained, you are highly intelligent individuals, and with just a few modifications, you can stay, I personally believe you can still image fairly safely because you're doing imaging through, and you can still acquire decently good images. You just have to work with the types of artifacts you may encounter and some of the other issues, such as a little bit higher technique factor. So I guess we can just turn it over to questions if people have any.
Thank you so much, Sam, for giving us some aspect for the physics. How can we adjust the parameter on the KVMA? And also, like you mentioned about we should take off the filter that we already have because we have a filter in the environment, so we don't need a filter in the machine. So yep. This is a good thing to know. Let's see. So we also have Dr. Vivatana. You guys have met like on the IR session,
yeah.
And actually he is a chest radiologist. So he is the one who read a lot of COVID patient, I guess, and exposed with the COVID patient and the situation in the southern part of Thailand. So สวัสดีค่ะอาจารย์เน่ง
สวัสดีครับ Hello Sam.
Hello again.
Hello again, yeah. So อาจารย์เน่งค่ะอาจารย์เน่งมีคอมเมนต์หรือมีอะไรเล่าให้ฟังเกี่ยวกับสถานการณ์ของทางมอไหมคะของโควิดว่าในโรงพยาบาลสนามหรือว่าอะไรเนี่ยมันมีปัญหาหรือทำอะไรที่ทำไอ้พวกนี้บ้างไหมคะ
Okay.
I asked Dr. Vivatana to tell about the situation in the southern part of Thailand and in his hospital, what he is doing right now.
Wonderful.
Yes, Thailand right now we face with the third wave of COVID pandemic, which is much which involve many patients more than the first time and the second time. During the first wave and second wave, we had enough beds in the real hospital for the infected patients, but this time we don't have enough for them. So we need to select the patients, which one for the real hospitals, which one for the field hospital.
Mhm.
For the field hospital, usually the patients are asymptomatic and we use chest X-ray to manage. We don't use X-ray for detection or for diagnosis, but to manage the patients. So the patients who are asymptomatic and negative chest X-ray, they will be referred to the field hospital, something like that. And chest X-ray, chest radiographs are done not every day, but very often for the mild patients to make sure that there is no lung involvement. And for the COVID-19, the early lung involvement, the radiologists they need to observe the lung markings, the lung vessels very carefully, because early infiltration will make those lung markings blur, something like that. But I find that most of the radiographs from the field hospital, the sharpness of the lung markings are not so good. So sometimes we need to repeat many times, before making sure that there is lung involvement. So I would like to, I think the patients in the field hospital, we don't expect to see big things in the chest. We would like to see very subtle, very faint findings, very subtle increased attenuation in the lungs by observing the sharpness of the lung vessels, something like that.
So อาจารย์คะ so what technique do you use at the field hospital? Do you your technologies increase the KV and adjust the MA level as well, or do you know?
No. I don't because we are radiologists. Sometimes we don't know. But this is I observe that this is the problem. So maybe we need to explore, or maybe we need to would like to hear your comment that what point we need to focus on, or to evaluate, or to explore. Maybe they don't use grid. Maybe they don't use grid as you said, or the KV they use, something like that.
Yeah. So if you're imaging in the field hospital, they're asymptomatic, therefore they're probably ambulatory. I'm not certain if you guys have set it up where
Sam
หายไปแล้ว
Sam, we cannot hear you. I think you have some internet connection issue. Hold on. Let me text him. Hold on. Let me. Hold on. Oh, he kicked out. Sam, welcome back, Sam. Let me unmute you. Hold on. Welcome back.
All right. Can you hear me now?
We can hear you now.
Okay, now we have you.
Yeah. Perfect. And so
Yeah.
the question was, how can we improve imaging, especially in the field hospital where we're looking for subtle findings?
Yes.
In this case, these patients, as you mentioned, are asymptomatic. So they're most likely ambulatory. They're probably people we can talk to. We can ask them to hold their breath. So we can image them in an ideal situation. Now, I don't know exactly how you're doing it, if the mobile unit will come to them or if you've set up one location and they'll go to it. But if you do this, I highly recommend using grids, because you can set it up so that the patient are either seated or they're standing erect, and you can get the grid in a good location. You make sure everything is perpendicular. You remember as close to the detector as possible so that we can improve the spatial resolution. If we are off, remember the magnification, we get an anatomy that's magnified, but we also will blur the edges of the anatomy. So the closer we get the anatomy to the detector, the better. Good collimation obviously makes for the gray-white imaging. But here, what I'm hearing from you is you really want to see the vessels, and you want to get good resolution. And so my comment is make sure you got a good grid in. The technique factors will be just your normal technique factors, because you're not imaging through glass. I'm guessing you're not, and you're probably not imaging in any weird situation. It's just a normal. They might be in a bed, they might be in a chair, like a wheelchair. So go back to the basics, the fundamentals.
To the basic standard, because patients in a few hospitals, usually they are young. This time they are young and asymptomatic. They can help themselves.
Yeah. So in that case, it might be helpful though in the field hospital to set up one room for imaging. So the mobile unit will be stationary. The patients will come in, and it's something where you can control you can keep the infection rate down because you can wipe everything down. But what you could do is you could set up a holder for the detector. So they just walk in, they hug they'll hug the detector like they normally would. You get the image, and then they're done, and they can walk away. And you don't have to worry about repositioning. You don't have to worry about the grids coming off. If you can get it set, then they just walk in the room, you get the image, they leave, and you sterilize everything, bring the next patient in.
Like a normal situation.
Yeah, except for with a portable unit. Yeah.
Thank you.
Yeah, no, and good luck. Thank you for all you're doing.
So there is like the questions about the things that Dr. Vivatana comments on, that we want to look for the sharpness on the fine details of the lung parenchyma. So is it better if we use a small focal spot to increase or improve image sharpness and reduce penumbra?
Yes. In this case, because unless it's a really big patient, we're not imaging through glass, so we don't need to change our KV real high, and we don't necessarily need to increase the MA real high. And if we don't have to have a real high, so if we have a 2 or 4 mass, then we can usually use the small focal spot.
อาจารย์ปานฤทัยมีคอมเมนต์ไหมคะ
ไม่มีค่ะ
Let me see if we have any other comments on the chat box. So I think like right now the situation in Thailand, in few hospital, mostly the patient can walk.
Yeah.
So it may be easy to do stuff, but the issue is in the hospital. Then we need to do like a 2 glass technique or like an isolation. And the issue is in Thailand, in some hospital, we have only 1 or 2 technologists.
Oh, yeah.
So that create an issue that they need to work maybe almost like a 24/7, and they need to protect themselves with the lead aprons and also the PPE, which is very heavy. And the weather in Thailand is very hot.
Yes.
So, yeah.
Yeah.
Any comment?
So I don't know exactly how your ICUs are situated, but if they have the glass doors so that the rooms are cut off from the patients, obviously they're in their PPE. But if there's enough room in the hallway, they can set it up, and then they can step back. If they can step back 2 meters, then they won't necessarily need to wear lead. Now, I make that statement. I don't know what the laws are in Thailand. In the US, we have specific laws that say we have to wear lead. And so our technologists have to wear lead, even if they step 2 meters back. If there is no law in Thailand, then maybe what they do is they just sit it up and then they step back and then they pull the trigger. And as long as they're far enough back, they will be fine. Scatter will not be a part of that. And at least they won't have to worry all that lead all day long, because that is really heavy.
Yes. Any comments from the audience who is a technologist on the situation or any issue or any questions that you want to ask Dr. Sam or Brady? No, it's very clear.
Yeah, unfortunately, everyone's just living with this situation.
Yeah, we just need to adjust. Yeah, on this.
Yeah, you know, you technologists are wonderful. And so you're doing a very difficult job in a very difficult situation. You know, obviously being uncomfortable wearing lead and PPE all day long, you're around sick people. So, you know, I'm so grateful for the technologists. They're amazing.
Yeah, we are so grateful for them, and we are so lucky to have our technologists to help us taking care in this process. Yeah. Okay, so I think we are done for today. อาจารย์ปามี comments มีอะไรเพิ่มเติมไหมคะหรืออาจารย์เน่งมีอะไรเพิ่มเติมไหมคะก่อนที่เราจะปิด session วันนี้ Okay. So thank you so much, Sam, for giving us an idea about the imaging technique optimization in DR and CR, and also how to integrate the physics knowledge in the unusual COVID situation that we are facing right now. So thank you so much. And next week we still on the CR and DR technique. Then we are going to talk about the dose optimization, right?
Yep.
The dose metric, and also how to set up the dose alert level on the DR and CR, right?
That sounds good.
And as usual, so after this talk, we're gonna send a link, this evaluation link for the people who want to get the CME credit, and we want to hear the feedback from you. What can we do better, or what topic that you want to learn more? And please complete the link by Thursday midnight, and on Friday you will get the CME certificates and also the link for the next week. And we're gonna meet again next week at 9 a.m. and hopefully the COVID situation is getting better. So please wash your hands, social distancing, stay home, and be safe. And I also would like to thank our sponsor, the Bayer, GE, and Philips, to support this educational course during this difficult time for us to learn about this thing. So thank you so much, everyone, and see you all again next week. สวัสดีค่ะ Thank you. Have a good night, Sam. Stay safe, everyone. Stay healthy.